was a pivotal for establishing the robust cross-border disease surveillance and even control network across Africa. For instance, I will talk about the CDC, the African Center for Disease Control and Prevention, the regional integration of the surveillance and lab network, and various cross-border disease surveillance program. All of this exemplifies the power of diplomatic coordination in strengthening surveillance at the point of entry, and providing the crucial training for the frontline health personnel, and even effective link this disparate nation surveillance system to enable the rapid outbreak identification and coordination. So, through this sustained diplomatic engagement, the African state can harmonize the data collection, the protocol, integrating the early warning system for emerging threats, facilitate the seamless flow of the really health information by negotiating and even then for data for sharing the agreement among the member states. They are significantly reduce the reporting drive for the disease outbreak, and even by doing so, will improve the continental strategy and resource mobilization. Speaking of the fundamental framework like integrated disease surveillance, it really underscores the importance of disease timely disease detection and even reporting sometimes. So, the health diplomas lay an essential groundwork for establishing sustainable and equitable cross-border healthcare access. That's why today we are here discussing now why there is a need of diplomas in Africa. So, when you speak about defining the national regulation concern, maybe about the drug approval processes, the vaccine registration procedures, the broader public health policies, often present a significant impediment to the effective regional health operation and equitable distribution of essential medical product. So all in all, that different organ, different stakeholders, there is a need to have a connected so that we can give a ripple effect when it comes for addressing this disease. Different actor and mechanism, Africa Union stand as the central political and diplomatic body by providing overarching guidance for continental health strategies through their specialized agent, the African Center for Disease Control. African Union actively implement the crucial framework, such as the new public health order for the Africa, which is strategically emphasizing enhanced leadership and coordination, promotion of local manufacturing of essential medical products, fostering innovation in health technology, and strengthening continental-wide emergency preparedness and response capabilities. So, among the actors and the mechanism behind African Union is doing a role. Furthermore, it provides the vital platform for the member state to develop a unified and coherent position in a key global health reform. African Union is among of the actors, but we have so many. We have the regional economic committees. To be particular, is the Economic Community of the West Africa, ECOWAS. We have Southern Africa Development Community, SADC. We have East Africa Community. All of these can effectively instrumentalize the health cooperation among the respective member states and give the desired outcome. All in all, what could be the future direction now? By understanding the need of the health diplomas, and even we have a very common shared thread when we talk about the sub-Saharan Africa and even Africa at large. So this evolving landscape of the global health presents several promising emerging opportunities for strengthening health diplomacy in Africa. So generally, the rapid advancement of the digital health diplomacies, it offers potential for establishing interconnected cross-border digital health system, facilitate the security sharing of patient data across boundaries, and deploying innovation to improve the continuity of care and expand the access to specialized medical experts in remote. Proactive diplomatic engagement will be essential to ensure the cross-border, and even speaking about the climate health diplomacy, then another critical area that we need to focus as an African, just in a few directions to strengthen. I underscore the effort that has been made of the African Union and different actors in this health diplomacy. Also, we need to think about the youth and gender inclusion must be must be mainstreamed into the health diplomacy as well. And this actually involve active leveraging youth read initiative in health education, advocacy campaign, and securing adoption of the gender responsibilities health diplomacy within the regional treaty and agreement to address the specific health need and the vulnerability of women and young people. The sustainable financing mechanism is among the critical area now. When we define our diplomacy as African continent, we should be in a position to come with the strategic and sustainable financing mechanism. We have witnessed a withdrawal fund from the donors. Now we need to think about that. But by leveraging health diplomas, we can come up with an agreement and even mobilize our domestic fund so that we can tackle different problems. Speaking about the pandemic preparedness, through the robust access diplomacies, we can negotiate and establish equitable negotiation framework for the development, production, and distribution of essential medical countermeasures, strengthen cross-border collaboration, research in development, and even ensure the fair allocation of resource during the future AIDS crisis. So all in all, next slide, please. The next slide.
ఇంకేం నెక్స్ట్ లైన్ బా
Yeah, so all in all, speaking about the health diplomas, stand as a tools for navigating the complex and interconnected challenges facing an African continent. So, the health diplomas
మళ్ళీ మీకు 11 12
is
స్టార్ట్
an
చేయండి
urgent need and an African in order to address the common threat that we are sharing, the growing burden of diseases, emerging and emergency care challenge. Health diplomacies is not only a need, but is the challenges demand the need of the health
ఐఎమ్ రెడీ
diplomacies.
అంట
So the active investment of different unities is really matters, and the
చెప్పారు
political will, it really matters when it comes for the health diplomas. Generally, the continued commitment to strengthen the health diplomas will be an essential truth in safeguarding the continent from existing emerging health threat, and even in advancing the collective pursuit of the health equity and well-being. Generally, let us join force in advocating about health diplomas, not only in Africa, but an African serve as a case study so that you can see the need of having a health diplomas, not only in Africa, but in global at large, because we have a very common shared threat. Now, health diplomas, it is a need, and these challenges pose a substantial need for us to come with health strategy. Join with me as we advocate for the national, as we advocate for the health diplomas in Africa for addressing the healthcare challenge. Thank you so much for your attention. Thank you for listening for me.
నెక్స్ట్ యానా
I would be happy to receive and to respond to questions that will arrive from the presentation. SC diplomacy is the key in addressing healthcare challenge in Africa.
అదే
Thank you.
మేనేజ్మెంట్ వీళ్ళు రెండు
Yeah, that's fantastic, Edward. Like, it's really nice. Like, you're there with us today, and you could share your thoughts and you could share your speech with us. And definitely, if there is anything, any questions on this, we'll definitely share them with you. And you need to answer those questions, because people with good enthusiasm, they may be sending the questions to you, and hope like you're going to answer them. So that's an excellent speech, and I request the people to give a good round of applause for this. Thank you so much. And I would like to move on to the next speaker, that is Anna. So Anna, she is an LLB honors, and she's a renowned expert in digital health and global public health at the same time, and she has got a very strong background in law, technology, and healthcare. And Anna is a founder of Dizzy Health Academy, and she's a co-founder of Masters in Global Health program. And she is also a scientific staff member for a decade, and she's also a president of one World Medical Network. That's a non-profit organization, and that's really excellent, Anna. That's really great you are here. So Anna is a multilingual, and she's fluent in German and English, and she's professionally proficient in French. That's really excellent on her part. And now I take this opportunity to welcome Anna onto the dais, and she's going to start with a speech. That's great, and you can start with your speech, Anna. The stage is all yours now. Thank you so much.
Thank you very much. Will you share my slides?
Yeah, sure, yes.
Okay. I would like to introduce myself again a little bit in a additional way, different way. Of course, everything was right, what you said. First of all, I would like to thank you that I can be here at this interesting conference about public health and nursing. Now, as you already mentioned, I'm the president of One World Medical Network. There, I get all my practical experience. And because in One World Medical Network, we are doing projects. My colleagues and me, we do projects all over the world, mainly in low and middle income countries. And it's always about health, and it's always about digital health. And I'm also the CEO of Cluecomer, the company, where we also develop software. We develop software which is then also used in projects. So we get a feedback from the practical side to the theoretical side, and we can implement in the theoretical side what is needed in the communities. And as you also mentioned already, I'm also the founder of Cluecomer Academy, because as we found out or realized in our practical experiences in the project, it's so important also to train people. It doesn't help a lot, to provide with software, with hardware, and then say, here you have telemedicine, you have digital health. Why don't you use it? We found out it's so important to train people about different topics, not only about digital health. We train people about what is public health. Yeah, what is it? That is so important. And therefore, now, what is public health? It is not only the practice, but it is also the science of healthcare and how to prevent diseases. That is what I taught at the university, because I taught digital health and public health to students, to international students from all over the world, because as you said, I am in Germany, and in Germany we teach normally in German language at university. But I was at a special university where there was one complete faculty where we only taught in English, and we accepted people, students from all over the world. So 99% of all our students were from abroad, and most of them were from, let's say, from Asia, from Africa, and they came to study. And here I also gained a lot of insight about what people know about digital health, what they know about public health. And therefore, I know that there is a lot to do. And therefore, I appreciate very much also that there is this conference where we can talk about it. So, now, public health, we already know. Now, the question is, how can we combine public health, nursing, and digital health? Do they belong together? Is there something which is important, why we need all three of them? And that means, yes, public health is, it focuses on the health of the population, and nursing focuses on the health of individuals and families in the communities. And digital health It provides tools which allows nurses to improve healthcare and to improve public health. So all these belong together. Now, nurses are at the front of healthcare. They talk to, or they have contact to the families. And now it's so important that they have a good understanding and a good connection, not only to the patients, but how can nurses get connected to specialists, to doctors, when they are in areas where there is no doctor. And in many low and middle income countries, we have this problem. We see that problem. And I also want to mention one other important topic, which is universal health care coverage. And it means that all individuals and all families will be covered by a good health care, so that the health in a country becomes really good for everybody, and not only for those who can pay and pay out of pocket. Okay, now please go to the next slide. I show you two pictures. One picture is from Mongolia. Maybe you haven't been to Mongolia yet. I have been there. I implemented a project for nurses in rural areas, as well as the other picture is from Brazil. And we also implemented a project in Brazil. Now, maybe you can imagine, Mongolia is a big country, but with only about 3.5 million inhabitants. More than half of the inhabitants live in the city. The other half lives in the country, in the rural area. And the rural area looks like what you see. This kind of yurts or tents, this is where people live. They don't have good health care in that area. They have smaller medical centers around, but very small. Very often there is only one nurse there and no doctor. Similar or completely different, if you want, it's in Brazil. Brazil is also, it's a big country, but you have a lot of trees. You have the Amazon, you have a jungle, but there also, you don't have doctors, many doctors, you don't have hospitals. So the nurses are the main caregivers in those areas. And now we come to a point which is also important, all the sustainable development goals. Here I want to point out SDG 3, it's good health and well-being. It's SDG 4, quality education, and SDG 5, gender equality. Can you imagine in countries like Mongolia or Brazil in the rural area, how to combine all these SDGs? It is important that you are connected, and you only can be connected when you use digital tools, when you use platforms, software platforms, where you can connect. Okay, next slide, please. Now, you see another picture. This is Iowa. Iowa is not in a low and middle income country. Iowa is a state in the United States. But below, you see a picture of Iowa from the countryside. And I've been to Iowa, and I saw Iowa is a really wonderful place, but it's rural. And when we talk about United States, very often we think about New York, Chicago, San Francisco, and so on. No, you also have, United States are a big country, and there you have also rural areas, and also in an area like in Iowa, it is important to connect nurses and doctors and patients, and therefore you need a digital health software, hardware. Now, what are the challenges when you are in rural areas? You have long travel distances between patients and nurses and hospitals. What you can use as a digital solution would be a video conference, which allows secure video consultations. And not only with patient and remote doctors, but also with nurses. And here I want to talk about or mention an experience I had in Brazil many years ago. And I can tell you, Brazil is very advanced when it comes to digital health, to public health in remote areas. There I saw nurses who had a mobile phone, a smartphone, and that nurse was connected with a patient. She was connected to a doctor, and they had excellent exchange with patients who live far away from the next hospital. So this is possible. This was already done years ago, and this can be done in certain areas where it's not done yet. And especially it's limited access to medical specialists. Imagine, so what we did in Mongolia, we implemented a telepathology project. And it was about doctors who were physicians, general practitioners, patients who had cancer, because telepathology you always need when you have a patient who has cancer. And there were experts in the capital city who were cancer or pathology experts, oncologists, and they were connected even to doctors from the United States, to experts, and from Germany. And they all figured out how critical is the health of a cancer patient. And that is possible when you have certain platforms, digital platforms. So, and next is not only to see a patient, because very often people think, oh, telemedicine, that is when a doctor sees a patient. No, that's not all. So it's also about, for example, paper-based documentation. You know, it's very hard when you have in a hospital or a nurse writes everything on paper. Nobody else can see what she writes. So it's important to have a collaborative online electronic health record, an EHR, which offers structures and digital case files about the patient. So no matter where the nurse is, where the patient is, where the expert physicians are, everybody has access to these EHRs and can see what is important for and about the patient. Okay, please, next slide. Okay, now we have now the densely populated urban areas, which is completely different to the rural areas. But nevertheless, you have a big problem there. And as I told you, I'm also working in Africa, and the left picture is from Ethiopia. It is from a rural area, but still it's a city. So here you have twice the problems. In a rural area, you don't have expert doctors, but many patients. And so you have to connect them, the doctors with expert doctors again. On the right side, you have a picture. It's about, it's one of the biggest favelas, areas in Rio de Janeiro, in Brazil. And there you have really many patients, many the population is high, the number of patients is high, the number of nurses is not so high, and the number of doctors is really low. So you have to find solutions for these patients, for the healthcare. And I remember it was in Rio de Janeiro. Also, I realized that in Mongolia, when there was a measles outbreak, where when you don't know who exactly has measles, you cannot do much. But what they did in both, it was in both cities. It was in Ulaanbaatar in Mongolia. It was in Rio de Janeiro in Brazil. Nurses used a mobile phone, and they had it's kind of a form on their mobile phone, and they went from house to house and asked people, how many people live in here? How many people have, or does anybody have measles? How many have measles? How old are the patients in the house who have measles? And they just said, click, click, click on their mobile phone. They went to the next house and did the same for weeks. And then they created a map with all those data, and they found out where are the clusters of measles. And they could, they sent doctors to those houses where there were measles to find out are there other diseases as well. They vaccinated people. They isolated really certain areas completely for, let's say, 1-2 weeks, so that they didn't leave the area, and they avoided that other areas got infected as well. And this was only possible with digital health, with those smartphones, with a digital, with an app on it, and they could collect data, and then they even shared this information, the data, with the ministries of health, and it was so valuable for epidemiology, because all of a sudden they had an overview what happened in an area like you see in Rio de Janeiro in that favela. Okay, next slide, please. Now, let's go through the challenges again in densely populated urban areas. So you have an overwhelming patient volume. And again here, an electronic health record, as I explained it for the measles, but it's not only for measles, but it can help you to collect data, to use data. You can think about other diseases as well. It can be diabetes. It's very important to understand where are diabetes problems, or where are problems of cancer, where are problems of, let's say, especially for women, also for pregnant women. Nurses can visit pregnant women at home and collect data and find out where could there be a problem in pregnancy. Where do pregnant women need more support by, let's say, by a midwife, by a gynecologist? This is much easier when you have an overview, okay? So, and that means you understand immediately where there are not only health problems, but also social problems. And when you look at the picture on the lower picture of this slide, this is a picture I took from a lady who lives in Ethiopia in very, very poor conditions. And there, you have to see that. You have to collect data from such an environment to show to the next social worker where the problem is. And again, you can have a video conference platform, which is sometimes important, not always, but you have to collect data. and you have to talk and, or let's say, implement the data and all the information in an electronic health record. That is important. And this is even, when, on the first picture, you see that was also in Ethiopia, how many patients you have in a rural area. This is not an urban area, how many patients you have. And you have to organize the system. Otherwise, people will not be treated well. When I saw only a few doctors and so many patients, I understood that it's not only providing digital health, but it's providing training to them, and it's providing help to nurses, because nurses are so important in such an environment. Doctors cannot do everything, and doctors should not do everything, treat every patient, because some diseases can be handled by nurses. Okay, next please. Yeah, so let's say the shared need. What is needed? And we can say efficient and secure communication. Why do I say secure communication? Because it is important for every country, no matter where, to have secure communication. I'm from Germany, I'm from Europe. We talk about general data protection regulation, but this is also important to countries outside of Europe. It's important to Asian countries. It's important to African countries. No country wants that data, and we collect data in that case, because when we have forms, we have to, we collect these data, and I'm sure, as we don't want that in Germany, we don't want that data from our patients are stored somewhere on a server in China or in the United States or I don't know where. We want to share data of our patients in a secure way. And that is what every country in the world wants. And therefore I say also in, let's say, in Africa, in Asia, data have to be stored in a secure way. Video conferences shouldn't be stored or recorded somewhere in another country where your country doesn't have control over. That is important, yeah? So therefore, secure communication. But it's also mobile and structured documentation. When once I was it was in a Mongolian hospital, and I asked, do you have documents which you fill, so kind of health record, patient record? And they said, yeah, we have it on paper. And I said, okay, can I see one of these templates just to see what kind of data you collect? And then they started searching for a document to show me that, which means they don't really collect data, even not on paper. But the best would be you have an electronic health record on your smartphone and you can collect data easily and share it with others. So this is very, very important. And this would make healthcare and public health much more efficient when you have data and you can analyze data. Again, epidemiology would benefit from such digital data very much. Okay, next slide, please. I would like to go through some use cases now. So, what about a rural primary care clinic? And that is very often primary health care. We're not talking about a clinic where surgery is done, but a clinic where even in primary care clinics, normally you don't do surgery there. Maybe very minor surgeries. But some primary healthcare clinics do have beds, others don't have beds. Yeah. But what you can do in a rural primary care clinic, you can have a few nurses, depends on how big the primary care clinic is. I've seen, again, in Brazil, very efficient primary care clinics, which had no beds, but which had several different departments. They had for first triage to find out when a patient comes, what is the problem of the patient. This was done by a nurse. She talked to the patient. Then she already could say, oh, this patient has this and that problem. So they had different doctors. They even had dentists. They had a gynecologist. They had a practitioner. They had a pediatrician. So this was, but without beds, and they all used digital health. They were connected to each other, and they were connected to the nurses. The nurses from the primary care clinic, they went to visit patients at home, and all the information they collected from visiting the patients at home was collected in the electronic health records, which was again shared with the primary care clinic, and all the doctors had access to this electronic health record. And when the patient came from home to visit the primary care clinic, they immediately could have all the information about the patient, which they collected the first time when the patient was in the primary care clinic, then which were connected when the nurse visited the patient at home, and when the patient came for a second visit to the primary care clinic, all the information was already there. I can tell you, this is sometimes what we dream of in Germany. So don't think we have everything that in Germany, we don't have it. We still built on it, and we are struggling with it. So, but I saw that in Brazil, and that existed. And I saw that partly also in Mongolia, and I was in Sub-Saharan Africa. I was in Rwanda. In Rwanda, they had very good results already with such a primary care clinic. I saw it in Ivory Coast. They were just discussing about how to do it. I saw it in Northern Africa, in Morocco. Morocco has, in some areas, quite good results already. They still have to improve a lot. But you see, we are all struggling. We are all trying to do it. But I just want to tell you what is possible and how easy it could be. Yeah? Okay, next slide, please. Okay. Yes, we already talked about digital solution applications. So it's mainly the nurse. She has all the possibilities to connect to the electronic health record. She knows, and it's always important that all the apps and platforms are easy to use. Okay, so because of course the training is needed, but it should not be complicated. Because when I talk to doctors, I tell them we developed, that is now my company, we developed apps and software and in a way that it can be easily used by nurses and doctors. Why? Because a nurse and a doctor are not software specialists. They are specialists in healthcare, and what they need is an easy to understand app. Very easy, and that can be done. So and it's about, when you can use an, let's say, ultrasound, when you use ECG, when you use radiology images, you want to concentrate on the pictures, because pictures can be shared as well, of course, yeah? So you want to concentrate on that, on diagnosis, and not on how to use the software. That is important, and that is what we are doing. And by the way, we even have teleconsultations with built-in translation functions. That means when a doctor speaks in one language and the patient doesn't understand that language, it is automatically translated through the app on your mobile phone into different languages, which makes also a lot of sense, because sometimes it depends in which country you are. Patients and doctors are talking in or speaking in different languages. So this has to be easy. Okay. Next page, please. Okay, sorry. I just wanted to explain why it is important also for digital forms, not only for nurses or for diagnosis, but you can have, that is important for regulation, for legal regulations. You need, for example, a signature from a patient that he or she agrees on using digital health. That is important. You can do that with digital forms, and you also can use forms for education, for example, for patients who do diabetes self-care checklists, and then patients can fill them out and share them with the nurse. That means the nurse doesn't have to visit the patient every week, especially for diabetes patients or others. So they can communicate in a digital way, and still the nurse and the doctor are aware of the health condition of the patient. So what does it mean? The impact is nurses spend less time on repetitive paperwork. Patients receive faster access to specialist opinion without traveling. And clinical workflows are streamlined and more compliant with data security standards. By the way, specialists without traveling. I'm in contact, and we we are in connection with patients in Saudi Arabia. Patients who are in a very rural area, they have tooth problem, yeah, and they are connected through video conference, through forms. They fill out forms, and they can contact dentists, and dentists will then decide where they have to go, or whether they have to see a doctor, a dentist, and to see which dentist. And they contact nurses and say, okay, maybe the nurse can do something for the patient to relieve pain, for example, and then the nurse goes there. So this is also one solution. Another project we are just starting is in Egypt. It is about improving healthcare of women in rural areas in Egypt. There we also, now I think I don't even have to explain to you what we can do for these women and also for their children. Okay, next slide, please. Okay, now use case number 2, just briefly, it's mobile community nursing team. There can be nursing teams who connect with each other, and for elderly and chronically ill patients. And this can be in semi-urban and also in rural areas. I will not repeat what I already told you. It's about video conferencing, it's about forums and electronic health record. But I want to tell you why is it important, and that it's not only in low and middle income countries. We have that problem in, for example, in Germany. There are elderly people, and that is maybe special in Germany, because here elderly people live alone at home. They do not always live with their families. This is not because we don't love our older people. This is because older people want that. This would be now an extra presentation about cultural differences in different countries. I will not do that. But we have this problem, and they live at home, and they have diabetes. And very often they are obese. They have high blood pressure, and they do not move a lot. They lay in the bed the whole day. And when you lay in the bed the whole day, and that for weeks, you have problems with your skin, and your skin gets you have the surface of the skin is infected. And when you have diabetes, and for example, legs, you don't, patients don't feel the pain. And the problem gets bigger and bigger. And here we have this, we have as a solution, there are nurses visiting the patient. They take pictures of the leg, of the wound, and share it with a wound manager or a physician. And then the physician tells the nurse how to treat these wounds, or whether the patient has to be delivered to a hospital. So this improves a lot the condition of a patient, because otherwise, and this is a problem we have in Germany, we have, when you don't realize it early enough, there will be amputation of the leg. And this is what we don't want to have in our healthcare system, and we don't especially not have that for the patient. This is so much pain for the patient, and it reduces his quality of life. Okay, and now next slide. This is just a short remark that can be tablet-based. We can do it with a smartphone. There can be remote collaborations with different doctors and wound managers, with people who are specialists in wound infections. So this is only an example. I could give you many more examples, as you can imagine, as I have seen in my projects all over the world. Okay, now, next slide. Next slide. So, thank you very much. No, next slide, yeah. I hope this was of some kind of interest for you, and if you have any questions, you're welcome to contact me, and we can talk about projects. If you have questions, if you are interested in, or if you have questions because you are in a project already, you're welcome to contact me. Thank you very much.
Great, that's really excellent, Anna. So it's like great. I was really spellbound to listen to your speech. It's very interesting to me, and I felt like there are a lot of practicalities involved in it, and your presentation was awesome. Thank you so much for an excellent presentation. What you have done, that's really great. And definitely, if we need any people have any questions on this, definitely they're going to come back to you with the mail ID which you have provided. That's excellent.
Yeah.
Thanks a lot for your time, and a huge round of applause for the speech.
Thank you.
Yeah, thanks a lot.
Yeah, thank you for allowing me to talk here. Thank you.
Thank you. Great. Now I move on to the next speaker, that is Ezra Ahmad. So Ezra Ahmad, she is a professional speaker and a certified life coach and a nutritionist. and a manufacturer of skincare and healthy food products. Has got 7 years of experience in nutrition, and she holds a master degree in colon cancer nutrition too. And she moved to Saudi Arabia 2 years ago, and she's working now as a nutritionist. And now I take this opportunity to invite Ezra Mohammed to take over. And Ezra Mohammed, please, the stage is all yours now, and you can start with your presentation. I guess again there is some technical issue from her end, and I just want to wait for 2 to 3 minutes so that she can start with her presentation. ఏమైంది రెడీ అందిగా
ఇందాక ట్యాంక్ వాడు అంతా ఓకే అది ఇది అంది నేను
లాగౌట్ 2 hours కింద జాయిన్ అయింది కాల్ డిక్లైన్
జాయిన్ అవుతాము
చచ్చిపోయింది ఏంటి ఏముంది థ్యాంక్ యూ ప్లీజ్ కెన్ ఐ ప్రెజెంట్ ద ప్రెజెంటేషన్
ఇది కాదు అది కాదు
Emmanuel Obegu. నేను చూసుకోవాలి టైం తెల్మా లివర్పూల్ ఎప్పుడు ఇప్పుడు రాత్రా
తెల్మా ఇంకా టైం ఉంది ఇప్పుడు రాత్రి కదా
ఎక్కడున్నాడు వీడు
ఎమాన్యుల్ ఇక్కడ ఉంటాడు లేవట్
ఎమాన్యుల్
ఇది రెడీ అని జాయిన్ చేద్దామా
అది లైట్ తీసుకోండి sorry people, I could understand Ezra has got some technical issue and it's going to take a longer time for her to join the stage. So I would like to now invite Emmanuel, who is ready with the speech and very enthusiastic person, and he's a professor in hematology at African University, and is an prolific researcher known for groundbreaking work in hematology, immunology, and public health. And he has authored hundreds of peer-reviewed scientific publications, and his research has earned international recognition in areas like HIV, blood transfusion, infectious diseases, and sickle cell anemia. So I take this opportunity to invite Emmanuel. Emmanuel, it's the stage is yours. You can take the call now, please.
Okay. Good morning. Good afternoon, the participants, the organizers. He has already introduced me. I am Professor Emmanuel Obegu, and I'm working here teaching hematology in African University in Zimbabwe. Please, can you share my slides?
Yeah, definitely. We are going to do that. Yes, you can go ahead. Now it's there.
Yeah, so it's my pleasure to be part of speakers of this well-organized conference.
Great,
So I appreciate all the previous speakers. I appreciate all the effort the organizers have made. And today I will be presenting bridging gaps in sickle cell disease care, technology-driven solution. In fact, I have so much interest for the scholars, for the researchers, for some donor agencies that are in the house. I have so much interest whenever it comes to sickle cell disease. Sickle cell disease is a great burden to developing countries, low resource income countries, countries where malaria is endemic, particularly sub-Saharan Africa, that have been suffering from malaria because of that genetic advantage that is conferred on the body, hemoglobin S. Because of that, sickle cell anemia or sickle cell children will always persist within that region or endemic region, because it confers selective advantage, protective advantage for immunity, for protection, for life as a defense. And because of that, there will always be some people who have that sickle cell trait, which maybe if there is no proper genetic counseling, may result to the production having a sickle cell children. And it comes with a lot of pains, it comes with a lot of crisis, it comes with a lot of economic burden, both on the parents, on the society, and everyone is involved. So please, the next slide. I hope you can hear me. I hope you are hearing me. I hope everyone is hearing me.
Yeah.
Hello.
Next slide.
Okay. Yeah, sickle cell disease remains a major global health burden, particularly in low resource settings where access to special is limited. So traditional diagnostic and treatment approaches often fail to reach undeserved populations, leading to poor disease management and then high mortality rates. Recent advancements in technology, including artificial intelligence, telemedicine, and digital health interventions, are transforming sickle cell disease care by improving early diagnosis, patient monitoring, and personalized treatment. So the emergence of gene therapy, particularly CRISPR-based genome editing and lent viral vector-mediated gene correction, offers a potential curative approach for sickle cell disease. However, the high cost, ethical concerns, and accessibility barriers pose significant challenges to its widespread adoption. The next. Next slide. Okay, good. So sickle cell, of course, all of us know that is a hereditary hemoglobin disorder, which is a single point mutation in a globin point 6. Whereby there is a replacement of valine, glutamic acid by valine. And of course, some of you that are in nutrition will understand that better. Because of that single point mutation, it brings about the sickling of the cell, when particularly in the case of a low oxygen tension, and of course polymerization that of course with a hallmark of inflammation, which triggers vaso-occlusive crisis, and then resulting to pains both on the joints, both on the chest, and then of course reduce oxygen perfusion, and of course this will come with a cardiovascular issue. So it's a hereditary hemoglobin disorder that affects millions of people worldwide, with the highest prevalence in sub-Saharan Africa, the Middle East, India, and parts of Caribbean. And it is characterized by the production of abnormal hemoglobin S, which causes red blood cells to assume a sickle shape, leading to vaso-occlusive crisis, leading to chronic anemia and organ damage. And because of the anemic incidence, so many of them always visit hospitals. So many of them are hospitalized, admitted, and of course they are among the patients that we know that they are constantly transfused, and blood transfusion, we keep on saying, is to be for a last resort. So despite advancement in medical landscape or science, sickle cell disease remains a major public health concern. And that is why it's always attracting the concern of donor agencies for research, for projects, because those people are people, they are passing through pains, and these researchers are getting worried to get cure Of course, even though we have bone marrow transplant as a curative approach, but of course, it is only effective at a tender age, and it is costly. And of course, gene therapy, particularly gene editing therapy, is another way, but of course, it's costly, especially in low resource setting. So concern due to its associated complications and the limited availability of specialized care in many regions. So addressing these challenges require innovation in technology, technological solutions that improve diagnosis, treatment, and then disease management. The next. So one of the key barriers of effective sickle cell disease management is delayed diagnosis. Of course, in health setting, if you're able to get accurate, definitive diagnosis of any disease condition, of course, you are in the almost near to improving the life of a patient. But whereby there is a delay in the diagnosis of a sickle cell disease, of course, you will notice some of them having a very big stomach, belly protruding as if they are pregnant, and that is as a result of manifestation of hepatosplenomegaly because of much oxidation, much stress in them, particularly in low resource setting where newborn screening programs are either absent or undeveloped. Early diagnosis is crucial in reducing mortality and preventing complications. Yet traditional diagnostic methods such as hemoglobin electrophoresis and genetic testing are often inaccessible to many affected populations. Like the last speaker who dealt with the community health aspect, who visited a lot of places setting in rural areas, in low resource settings, to compare what happened there and then what happened in their own places. You will notice that most of those health centers, primary health centers, they don't even perform electrophoretic analysis to know the genotype, the hemoglobin electrophoretic pattern, the genotype of the children, even at early stage. And of course, before it is known, is because they are always sick. They are always sick and they are visiting hospital. Some of them discover that this child is a sickle cell child accidentally, not because they know that truly this child is a sickle cell child. And then, of course, if you give them proper care, proper treatment, proper management early enough, when you see them on the way, on the road, in the schools, you may notice you don't even know that they are sickle cell children. Looking at some physical examination, looking at some clinical presentation, you will not even easily notice. They live their normal life, they live long, they marry, they give birth. But of course, if you fail to diagnose it early and the level of fetal hemoglobin is not high to confer protection on them, they in fact inducing production of having a stronger affinity for oxygen. Of course, they will be having a constant incessant crisis, and that will be leading them to hospital. And both the parents, the society, the doctors, the clinicians, everybody in the hospital, everyone know that is a problem. And of course, my first degree project I researched was on sickle cell children. And of course, one of them that I collected sample from was asking me why among all the children in the house, she's the only one that is a sickle cell child. Why must it be she? And I told her, you cannot question God. You cannot challenge your mother. You cannot challenge your father. Why they gave birth to you? You are a child. You came into the world. Who are you to challenge the parents? But of course, I talk to the parents that are here listening to me. Of course, you people have children. You're also a parent. You have some of you are lecturers. Some of you are teachers. Some of you are working in different places. Please create awareness for this sickle cell screening. Create awareness, especially those that are in the rural areas. Before you know it, the teenage pregnancies, they keep on producing sickle cell children, and these children will be asking, why do you give birth? Why do you bring me to suffer in the world? You have not intentionally brought them to suffer, but of course you should know your genotype early enough, and this is a preventable occurrence. It is better to prevent it than handling it at a curative level. So telemedicine has emerged as a powerful solution to bridge the gap, allowing patients to consult specialists remotely and receive continuous care through digital health platforms. Mobile health applications and wearable devices now enable a real-time tracking of pain crisis, oxygen saturation level, and medication intake, helping both patients and healthcare providers to make informed decision early enough. Artificial intelligence and big data analytics have also contributed significantly to personalize care for sickle cell treatment strategies. So AI-driven models can predict the likelihood of a vaso-occlusive crisis, which we know is central to the problems, even to the untimely death of a lot of sickle cell patient children, by analyzing the patient data, including genetic markers, environmental factors, and previous pain episode. And let me offer this advice to the listeners. I know you don't have a sickle cell child, but you may know where they are. You may know the clinic, their clinic days. You may have a relative that is one of them. Please, you need those children. You don't need them to be so far from you, because some of them, a lot of environmental factors can trigger the vaso-occlusive crisis by initiating, activating the inflammation in them, and some cytokines are activated will now make the whole thing become excruciating, and sometimes it also leads to maybe thrombosis, and of course sometimes you hear that they even have a problem in their brain and they collapse and they die. And sometimes it is only a child that the mother has. Why are you leaving the child to go far? Because you know that time to time they have a crisis, except those ones that have a higher level of fetal hemoglobin. So techniques such as a CRISPR-Cas9 gene editing and a lentiviral vector mediated correction aim to modify the genetic mutations. Of course, but how many patients in a low resource setting can handle the gene therapy or gene editing method? Next. Hello, I hope you are hearing me. Hello. I hope the audience are hearing me. So now the role of technology in sickle cell disease diagnosis. Accurate and early diagnosis of sickle cell disease is critical, is paramount to preventing complications and reducing mortality, especially in high burden regions, especially in Africa, India, and Mediterranean regions. Traditional diagnostic methods such as hemoglobin electrophoretic pattern and high performance liquid chromatography remains the gold standard, but are often costly, labor intensive, and inaccessible to low resource settings. So the advent of technology-driven diagnosis solutions, including point-of-care testing, whereby maybe on the bedside you just collect blood as a drop and then you get the result immediately. So that one may not even need professionals. It may not even need the help of well-trained medical lab scientists or even nurses. Every other person in the health system and even the parents will be able to do that, and they know the result, the outcome, of course, and they know the best approach of interacting with healthcare providers or healthcare workers. Artificial intelligence assisted imaging, of course, this will collect a lot of data and data relating to the patient, to the child, the patient, analyze it, and then we'll be able to even predict at a time that the child may have a vaso-occlusive crisis, and of course that will be prevented, because in public health we talk much about a preventive stage, not a curative. It is better to prevent diseases spreading in the society. And then a digital data management system, which has revolutionized sickle cell disease by making it faster, more accurate, and widely available. Next. So one of the most significant advancements in the sickle cell disease or early diagnosis is this point of care, which I've already explained. The artificial intelligence, which everywhere in every sector now is utilized, and I encourage all of you to key into it. Utilize it in your profession, utilize it even as a doctor. You need to use it with precision, with a personalized medicine. Now, the people in pharmacology or pharmacists, you produce drugs that are tailored towards the need of a patient, because of course you know about gene variations. Even if they are from the same parents, they will not respond to the treatment the same way. Of course, you tailor it towards the need of a particular child, knowing that genetic variations will also affect a response or improvement or prognosis of these children. The next. So additionally, genetic testing technologies have also advanced significantly, making a DNA-based diagnosis of sickle cell disease more accessible. Techniques such as polymerase chain reaction, next gene sequencing allow for precise identification of hemoglobin gene mutation, enabling a definitive sickle cell disease diagnosis and carrier screening. So another major breakthrough is the use of biosensors and then lab on a chip device for sickle cell disease. So this microfluidic technologies require minimal blood samples, so it is less invasive. I say create less pain because there are people you ask them to show their, let us collect your blood. It is invasive, it is painful, so and can rapidly assess hemoglobin properties, providing efficient and cost-effective diagnostic alternatives. So digital health solutions such as electronic health records, as the other speaker mentioned, and then cloud-based diagnostic platforms also play a vital role in streamlining sickle cell disease diagnosis. So this system enables healthcare providers to store, assess, and shape patient data efficiently, facilitating a better coordination of care and long-term disease monitoring. And let me say this, there are a lot of hospitals you go, if you see the way they store their information about the patient, you know you cannot draw any clinical decision without the way they store it, whether in the computer, whether as in the file, in the maybe a manual, anyhow they do. But health information about the patient are very, very important in making decisions, of course, again, in predicting what happens in the society, even in 5 years or in 10 years coming. And then, of course, the donor agencies, the policy makers will use it to make a better policy to help the humanity, because the public health is just there to make sure that there is an increase in health. And the population, the citizens, the people in the society, they live healthy, they enjoy the environment, and even the people, their own offspring, the people coming after them when they have left here, the place is also safe for them. Next. So telemedicine and digital health for patient management in sickle cell disease. So one of the most impactful applications of telemedicine in sickle cell disease is remote patient consultation, which enables individuals to connect with a hematologist and other specialists without the need for frequent hospital visits. Of course, to reduce a lot of stress, to reduce a lot of hazard on the road. Of course, if you go to maybe some Sub-Saharan Africa, developing countries, most countries may not have even accessible roads. A lot of places are vulnerable, people are vulnerable, a lot of crises are going on in the society. To reduce all those problems, you can connect to the hematologist, connect to the health experts, even electronically through where you are, because thank God these days network of internet has made the world a global village whereby you can stay in your door, you can see what you are doing, you are in your place in different countries, in different continents, and all of us are interacting as if we're in the same conference hall, seeing ourselves, and it looks like a real life situation. Virtual consultation via video calls, phone calls, on mobile applications allow for continuous medical supervision, reducing unnecessary emergency visits and hospitalization. Mobile health applications have significantly improved patient self-management and adherence to treatment regimens. So these apps allow patients to track their pain episodes, monitor medication intake, and receive automated reminders for hydration, medication, and follow-up appointments. So some advanced applications such as a smart app for sickle cell disease, integrated AI algorithms that analyze patient record symptoms and provide real-time feedback on patient management. Of course, these applications will help even the parents to track, to monitor the risk of or the triggers around their children. And of course, they will know this, they may not leave for work, they need to stay around the children, monitor them, to ensure they take their drugs, to ensure that they are hydrated, because dehydration also causes a great inflammation on them, and that will trigger even the vaso-occlusive crisis, which is a crisis state, and that will need attention in the hospital. And not just that, it also leads to anemia. And of course, remember, their hemoglobin level are perpetually low. Even, of course, if you see that in a normal human being, they will not be able to be moving around, but because of compensatory mechanism from the bone marrow, they are also moving around. But of course, you have to maintain that their hemoglobin level at a steady level, of course, so that they will not be facing incessant crisis. The next. So wearable health technologies are another game changer in sickle cell management. Devices such as smart watches. Of course, these days you are lecturing, you are teaching students. Some of them, you see watches on them. You may not know that they have a wearable health technology, and of course, or some other things, dictating tools they use. As a biosensors are there, which can continuously monitor vital signs, including heart rate, oxygen saturation, and blood temperature. So these are the real-time data collection allows for early detection of potential complications such as a vaso-occlusive crisis or accurate Chase syndrome, enabling timely medical intervention. And of course, in this case, there will be reduced mortality and morbidity rate among the patients. And then AI and big data analytics play a crucial role in optimizing sickle cell disease management by predicting a disease exacerbation and tailoring treatment approaches. So AI-powered models analyze patient data from electronic health records, wearable devices, and self-reported symptoms to identify patterns in disease progression. And this will help the patient, help the parents, help all the health workers to know how to handle a particular patient. The next. So cloud-based electronic health record system enhance care coordination among healthcare providers by enabling seamless data sharing across different institutions. Of course, you remember the last speaker was talking about that, whereby even from one health worker to the other, you even approach hospital from the record unit, they get your, and then the people taking your vital signs. From there, they take the records straight to the next person, from the next person, so there's no need of carrying files here and there again. This is particularly beneficial for sickle cell disease patients who may require emergency care in different locations. So cloud-based platform ensures that physicians have instant access to patient medical history, test results, and treatment plans, reducing the risk of mismanagement and improving clinical decision making. So it makes the work faster. It makes the saving of the child to be even prompt. Instead of having casualties, instead of having on record a kind of preventable death, it will help to prevent the effect of what would have happened if there is a delay. Because in management of sickle cell disease, there is supposed not to be any delay. Any delay for them can lead to death. The next. So AI and big data in personalized sickle cell disease treatment. So one of the most significant contribution of AI in sickle cell disease treatment is ability to predict this vaso-occlusive crisis, which I told you is one of the major events that happen in them and is causing a major problem. So by analyzing a vast data set, including a patient medical histories, wearable devices, metrics, environmental factors such as temperature, humidity, and real-time physiological signals, the AI models can now forecast the likelihood of a patient crisis before it occurs. So because you're able to predict it, you now see that that child may not suffer that crisis. Of course, you will be taking a preventive precautionary measures to prevent, to avert that danger that may strike that child. So big data analysis also plays a crucial role in personalized pain management strategies for sickle cell disease patients. Traditionally, pain episode in sickle cell disease are managed using opioids and non-steroidal anti-inflammatory drugs. The response to these treatments varies significantly among patients because of gene variations. The next. Hello, next. So another breakthrough for AI-driven sickle cell disease management is drug repurposing and optimization of treatment regimens. So the AI models can rapidly analyze thousands of existing data or drugs to identify those with potential benefit for sickle cell disease. For example, AI-based drug discovery platform has significantly identified new uses for hydroxyurea and other therapeutic agents, which of course this hydroxyurea will help to induce the secretion, the synthesis of hemoglobin F, which will help to confer protection for this child. So machine learning in genomic research is further enhancing our understanding of genetic variation that influence sickle cell disease severity and disease and treatment responses. The integration of AI-driven clinical decision support system is also transforming a real-life time treatment decision in sickle cell disease care. The next. So advancement in gene therapy for sickle cell disease. So one of the most groundbreaking approaches in gene therapy is CRISPR-Cas9 based genome editing, which allows for precise modification of defective beta globulin gene, which where I told you is a single point mutation. So scientists are able to develop their strategies to either correct the mutation in the hemoglobin beta chain gene or reactivate fetal hemoglobin synthesis, which can now compensate for the defective hemoglobin S. So of course they would trace that gene where there is a kind of a disarrangement of amino acid order there, the codon there, and of course they will now correct it with a correct amino acid, and then the bone marrow started producing normal hemoglobin. And then lentiviral gene therapy is another major advancement in sickle cell disease treatment. This approach involves the use of genetically engineered viruses to introduce a functional copy of the beta globin gene into hematopoietic stem cells. So one such a therapy, lentiglobin BB305, has demonstrated a remarkable success in clinical trials, with a patient achieving near normal hemoglobin level and then reduce sickle cell disease related complications. And of course, I mentioned CRISPR-9 before. Yes, next.
Next.
So the challenges in gene therapy for sickle cell disease, one is a complexity and safety of gene editing procedure. You have to consider the complex nature of that, and of course it needs a professionalism. It's not everyone that can do it, and then of course the safety of it is also very important. Another one is a need for myeloablative conditioning. So before reinfusing of a genetically modified stem cell, patient must undergo myeloablative conditioning to eliminate existing bone marrow cells. This process involves chemotherapy, which can cause severe side effects, and of course that will also make you to be very careful of the use of it. Another thing is a high cost and a limited accessibility. I keep on saying it that is not something that poor people may afford. The government may be involved to help the patient, and of course sometimes you see that these children may come from low income parents, poor parents. And of course, they need the help of the community. They need the help of the society to even to afford some of this clinical, this healthcare. The next. Another thing is infrastructure and healthcare capacity limitations. Like the speaker that have traveled to some low resource countries, you will notice a lot of lack of infrastructure, lack of equipment to handle these patients. And ethical and social consideration. So gene therapy raises ethical considerations regarding its long-term consequences, especially with the genome editing approaches that induce a permanent change in DNA. And because of that, of course, ethical consideration must be considered. And long-term efficacy and durability. While initial clinical trials have shown promising results, long-term efficacy remains uncertain. So there is a research, the place is open for more research for people to come into it and explore the long-term and longitudinal research to know the effect of these treatments on the patients. And then patient and public perception. How do patient and the public perceive this approach? Misinformation, cultural beliefs, and skepticism towards gene therapy may hinder patients accepting these treatment options, because you need to convince them, you need to make them to know what the role, the benefits over the disadvantages before they will accept to go through gene therapy. The next. The recommendation for advancing gene therapy for sickle cell disease. You have one is advancing research on safety and efficacy so that the treatment will be very safe and they will be able to accept it, reducing the treatment costs and improving accessibility, and strengthening the healthcare infrastructure in low resource setting. Next. And then ethical governance and policy development. Of course, ethical concern regarding gene therapy, particularly related to genetic modifications, and potential disparities in access must be addressed through global ethical guidelines and policy framework. Another one is expanding education and public engagement. And of course, I suggest to a lot of people on that are in leadership positions and policy making in the educational system to incorporate sickle cell disease education to the even from second primary school, from the junior school to tertiary institutions, creating awareness, educating, empowering these children, and of course, when it is time for them to marry, to marry wisely, to ensure that they know their hemoglobin genotype early enough, and then marry with genotype that are compatible, that will not be able to lead them to produce a sickle cell children. Personalized approaches and tailored therapies. Remember the gene variations in each human beings. As I told you, the way each person responds to treatment is not the way another person responds. Even if they are even identical twins, they are the only close people that may respond in a similar way, but not exactly the same way, because of course there must be some variations that are traceable to cellular or molecular level. The next. Fostering a global collaboration and partnership is very important, just like this conference we are doing now. Of course, we align with people that have a similar research interest. I call upon some persons to go into research, to collaborate internationally to find a cure, to find a better way of improving the life of sickle cell patients. And again, monitoring and post-treatment care. You have to monitor them while you administer the treatment, and of course, even after the treatment, you follow them up to see development and then prompt approach to take care of them. The next.
సార్ 19 నెక్స్ట్ అవుతుంది.
In conclusion, gene therapy has emerged as a transformative approach in the treatment of sickle cell disease, offering the potential for a permanent cure for directly addressing the genetic root cause of the disorder, and then advancing gene editing technologies like CRISPR-9, lentivirus vector-based therapies, and base editing have shown promising results for early stage clinical trials. To maximize the impact of gene therapy in sickle cell disease, it is essential to address the challenges raised. And of course, it's also important that we maximize the technological advancement these days. Of course, the AI these days, a lot of development in technology, in machines, even laboratory-based machines, molecular approaches to make for early detection and then for proper management of these sickle cell children. And I encourage the sickle cell children all over the world to know that there is still hope for them. Let them be happy. Let everybody join hands to help them to live a better and a well promising life. Thank you so much for listening to me. And I don't know whether you have any question. Thank you.
That's excellent. That's really superb, and like it's a very interesting presentation, Professor. Like we could understand a lot about the sickle cell anemia, and that's really great that you are here today and you presented your speech here. I guess the speakers who are there in the panel, they might be very happy with the speech, and they might have got very good information about the sickle cell anemia disease. That's great. Thanks a lot. If there are any questions, definitely we are going to send you the mail, and please revert back for that. And guys, please a huge round of applause for his presentation. Thank you, Professor. Thanks a lot. And next, I'm going to invite Sagarika. She is a dentist and a public health advocate, and she has recently completed her master's in public health from University of Glasgow, and she has got very good experience in delivering dental and health services to the populations in India. Actually, she is from I guess she worked a lot in India. I guess that's nice. And she has got she has done some impactful programs in menstrual health, tobacco cessation, and nutrition. And that's really excellent. Like you went for this tobacco cessation. That's an excellent step. That's great. And she actually she's actually aiming to work to bridge the gap between grassroots activism and evidence-based public health practices. That's fantastic. And so Sagarika, it's all yours, and please go ahead.
Hello, hi.
Yeah.
Can you start my PPT, please?
Yeah, sure. We are going to share it for you.
So, thank you for the lovely introduction. I'm really grateful to be here today to speak about something deeply personal yet far too often overlooked: menstrual health. Menstruation is a natural biological process, and yet around the world it's treated with shame, secrecy, and silence. For many menstruators, it becomes not just a physical experience but a source of stigma, social exclusion, and lost opportunities. Today, I want to take you on a journey from stigma that isolates to the solutions that empower and ultimately to sustainability that includes environment, equity, and dignity. Together, we'll explore how menstruation connects public health, education, gender justice, and climate responsibility, and why it deserves a central space in how we imagine truly inclusive health systems. So, let's begin. Next slide, please. Menstrual health affects over half of the population, and yet it's still not treated as core public health issue. But this is more about hygiene. It's about poor menstrual health management, increases the risk of UTI, urinary tract infection, reproductive complications, and other preventable conditions, especially in places where access to clean water and sanitation is already limited. And when we ignore menstruation in public policy and planning, we also ignore opportunities to improve gender equality, mental health, and education. Menstrual health is essential for achieving multiple sustainable development goals, especially those related to health, education, gender equality, and clean water and sanitation. So, when we talk about menstruation, we are not just talking about periods, we are talking about public health, rights, and resilience. Menstrual health is not a niche issue, is deeply connected to education, mental health, gender equality, wash, that is water, sanitation and hygiene, and climate justice. So let's move to the next slide.
సార్ మెటాలో పడ్డ స్క్రీన్ షాట్లు కూడా ఎడిట్ చేయాల్సి వస్తుంది.
Next slide, please. Yeah. So let's discuss the persistent stigma of menstruation. So, research shows that 60% of the adults report that menstrual stigma affects how comfortable they feel in their own bodies. Cultural taboos, shames, and secrecies are deeply rooted. In many communities, menstruating girls are not told to enter temple, kitchens, or even classrooms. They are taught to hide pads, stay silent, and to pretend as if essential part of life doesn't exist. This stigma doesn't just lead to awkward conversation or lack thereof. It creates a cycle of silence where misinformation spreads, support system fails, and girls feel what's happening to their body is somehow wrong or shameful. I want to share a moment that deeply impacted me. So you can see a picture, and there is a girl in red. So it was my talk during a menstrual health session in a village near Nagpur. So I was speaking to this group of girls, and one girl, Rani, sat quietly the whole time, watching but not saying anything. And after the session, she came up and she said softly, Didi, I thought I was bleeding because I did something wrong. This moment was really heartbreaking because what should be a sign of health was for her a symbol of guilt. This is a power of stigma. It doesn't just affect how we talk about
Yes, ma'am.
menstruation,
Very
it
interesting
affects
and
young girls
well
see
explained.
themselves, their worth, and their place in the society. Next slide, please.
పాపం ఏం చేస్తారు చూడండి మరి.
So let's see how it impacts health, education, and well being. Menstruation, when unsupported or misunderstood, can have a domino effect on a person's entire life, starting with their education and rippling into their health, confidence, future opportunities. Let's start with education. Around the world, especially in low and middle income countries, many girls miss school during their periods. Some miss up to 20% of school year, and others eventually drop out completely. Why? Because they lack access to products, there are no safe private toilets at school, or they simply are too embarrassed to be seen. The result is devastating, not just academically, but also psychologically. Every school day missed chips away her confidence, her sense of
అలాంటి
belonging.
రాజశ్రీ ఒకటి
Then there's a
ఇంగ్లీష్లో
physical health.
లాగారు.
Girls who don't have access to proper menstrual products often resort to unsafe alternatives like old clothes, newspapers, sawdust, or even ashes. These practices increase the risk of infection, rashes, and reproductive health issues. And due to shame, may never speak up, seek help, which only deepens the problem. Mental health is affected too. Shame, secrecy, and teasing create feelings of anxiety, low self worth, and fear. Some girls are bullied for leaking or for simply carrying a pad to toilet. There's also a broader social impact. In some cultures, menstruating individuals are treated as unclean. So here you can see a image. It's something called chopadi in Nepal, where menstruating women are made to sleep in huts or cow sheds, often in rash, unsafe condition. Some have even died due to snake bites, cold, smoke inhalation. These practices, from subtle shame to outright isolation, show us one thing: menstruation is not just a private issue, it's a public health challenge, it's a mental health issue, it's a barrier to education, safety, and dignity. And if we don't address it systematically and compassionately, we risk leaving millions of girls and women behind simply for having a period. Next slide, please. So now let's talk about global reality of period poverty. One of the most urgent and visible consequences of menstrual stigma and neglect. Period poverty means not having access to menstrual products, clean toilets, safe disposable facilities, or even accurate information. But at its core, period poverty is not just a lack of products, it's lack of choices, dignity, and power. Today, more than 500 million people worldwide experience period poverty. In India, around 70% of women say they cannot afford sanitary pads. In sub Saharan Africa, it's estimated that 1 in 10 girls miss school during periods. And in marginalized communities, whether it's slums, refugee camps, or remote rural village, access is even worse. Without pads or clean toilets, many girls use unsanitary alternatives like old rags, newspaper, cotton waste, or even soil and ashes. Not only in this is physically harmful, but emotional toll is just damaging. Even in high income countries, many low income menstruators ration pads, use products for longer than safe, or miss work or school. Period poverty disproportionately affects young people, trans, non binary menstruators, people with disabilities, and those from marginalized ethnic backgrounds. When someone can't manage their periods with dignity, they are not just comfortable, they are being denied a basic human right. Period poverty hold girls back from school, women from employment, and entire communities from the progress. It tells a young girl that her body is too expensive to manage, that she can't afford to bleed, and this is simply unacceptable. Let's move to the next slide. So, when we think about menstruation, we often focus on access and affordability. But there is another side we urgently need to talk about: the environmental cost of how we manage periods. A single disposable pad can take 500 to 800 years to decompose. And in India alone, over 12 billion of these pads are discarded every single year. Most of these contain plastic, the equivalent of 4 plastic bags per pad. Now multiply that by every menstruator, every cycle for decades. But the harm goes beyond just environment. For the consumer, these pads can cause rashes, irritations, and exposure to chemicals like dioxins and synthetic fragrances. For the disposer, usually sanitation workers, often from marginalized communities, handling used pads without protections possess serious health risks. And for the environment, they contribute to landfills, water pollutions, and when burned, air toxicity. In many places with limited waste management, burning is the only option. This means toxic fumes enter very air people breathe. This is a triple threat to the person using period products, to those forced to dispose of it, and to the planet itself. So, what's the way forward? we must promote sustainable menstrual products that are reusable, safer, and eco conscious, which can be menstrual cups, reusable cloth pads, and biodegradable pads. These alternatives are not just better for the environment, they are better for the health, for equity, and for long term affordability. And when introduced through community education and open dialogue, they are embraced, not rejected. Let's move to the next slide. So far, we have talked about challenges, but here's the good news: change is not only possible, it's already happening. What you see here on the screen are some moments from the field, from real reasons me and my team have conducted in communities, schools, and villages. These are the photos of young girls and boys engaging with information about menstruation, many of them for the very first time. One of the most impactful things we have done is organize period parties. Now I know that might may sound light-hearted, but it is actually incredibly powerful. These are safe, welcoming spaces where we create an environment of openness, where menstruation isn't widespread about. It's celebrated, understood, and normalized. In these sessions, we talk about biology of period, demonstrate how menstrual cups our reusable pads work, and most importantly, will listen. We answer to questions like: will a cup fit? Can I go to school while using this? What if someone sees me in the washroom using a cloth pad? We involve boys in the conversation too, because changing mindset isn't just a girl's burden. We can also train local peer educators because we know that change sticks better when it comes from within the community. And we partner with schools, NGOs, and health workers, building bridges between knowledge and action. What we see is transformational. Girls who were silent at the start became confident by the end. Curiosity replaces shame, fears gives way to agency. These aren't just photos, these are stories of reclaimed dignity, shared learning, and quiet revolutions. And it reminds me every time we don't need huge institution to change the world. Sometimes we just need a group, a room, and the right conversation. Let's move to the other side. Next slide, please. So, this photo captures something. No, one back.
Previous.
Yeah. This photos captures something close to my heart, a moment where our team was actively working on the ground to support menstrual health. What you see isn't just a campaign or a project, it's a collective commitment to inclusion, dignity, and gender justice. Because menstrual equity is not just about giving out products or running sessions, it's about reshaping systems that have for too long told menstruators to stay silent and stay small. Let's look why menstrual equity matters so deeply in public health and gender equality. Personal dignity. Everyone deserves to manage their periods with dignity. When we support menstrual health, we help people understand their bodies and feel ownership rather than shame. This isn't just about hygiene, it's about bodily autonomy. Non discrimination. Menstruation should never be a barrier. It should not keep anyone from learning, working, or participating fully in the society. Menstrual equity means building systems where no one is left behind because of their biology. Leadership. When we address menstrual health openly, we create a safe space for girls and women to lead conversation, to lead organizations, to lead communities. When a girl doesn't have to hide her period, she is more likely to stand up, speak up, and take up space. Next slide, please. We have seen the challenges. Now let's talk about what is working and what works. Real change is happening and it's being driven by bold policy, creative innovations, and strong community engagements. Policy setting foundation. In 2020, I have been in Scotland for 2 years now. Scotland has made a history by becoming first country in the world to offer fee period products to everyone in school, public buildings, and community spaces. Any public space you go here in Scotland, you can find menstrual products free to use. That law was built on one simple belief: menstrual health is a right, not a privilege. And it's just not Scotland. Wales and New Zealand provide free products in school. In Kerala, India, local governments have introduced pad vending machines for and free pad distribution programs in public schools. These are the examples shows us what possible when policy takes menstrual health seriously. Innovation changing the conversation. Innovation is not just about the products, it about the perspective. Menstrual cups are reusable, pads are cost effective, environmentally sustainable, and increasing welcomed when people provide under proper demonstrations. Creative outreach like period party, comics, peer educations, and interactive workshops helps break down the stigma and makes learning fun, not frightening. In my work, I've seen girls go from hesitant to confident, all because we approach menstruation with empathy and creativity. And let's focus on education. While we have already explored the role of education earlier, let me just say this: without accurate, age appropriate, inclusive education, none of these solutions are sustainable. Education ensures that products are used correctly, stigma is challenged, and knowledge has become innate. Let's move to the next slide. So, this is my last slide, my closing reflection. So, whether it's a law, a lesson, or a low cost cup, the solution starts with care and courage. And if after today you can convince even one menstruator to switch to sustainable product or even just talk openly about periods, that would be a win for them, a win for you, and a win for our planet. Because a period should never be full stop in anyone's life. Thank you so much.
Yeah, that's a fantastic presentation. The topic which is to be a secret is no more a secret, according to you, and the people should live with that particular stigma. That's really great, and you're doing a very great job. That's excellent on your part, Sagarika. And the presentation is also very perfect and very informative, and slides are presented very perfectly. Thank you so much for your presentation. And any questions, you can just send us, and we are going to definitely send it to Sagarika, and she's going to answer them. Thanks a lot for your time and your presentation, Sagarika. That's great. And now I just want to move on to the next speaker, that is Esra. Previously, because of a technical issues, she was unable to actually join the presentation, but now she's here, and I just want to give a brief introduction again regarding Esra. Esra, she is a professional speaker and a certified life coach, nutritionist, and manufacturer of skincare and healthcare products. And almost she has got 7 years of experience in field of nutrition, and she holds a master degree in colon cancer nutrition. And she is from Saudi Arabia, and she's going to take the place now. And Ezra, you please, you can start with your presentation. మళ్ళీ వచ్చింది ఇష్యూ దీనికి పిచ్చి లంచం ఉండదు రావచ్చు చదవాలి మూసుకొని కూర్చోవాలి.
ఇప్పుడే మాట్లాడాను సార్ దీంతో ప్రెజెంటేషన్ మెంబర్స్ ఆల్ నా దగ్గర ఉన్నాం ఒకడు రా అది అని చెప్పి అన్నాను.
Hello, everybody.
Yeah, hi Ezra. Yeah, can you
Hello.
share your presentation?
Okay.
Yeah, we are unable to see you. We want to see you.
Can you see me?
No. Yep, now we can see you. That's great. Yeah,
Okay.
Please go with the presentation.
Sorry from the problem. Sorry.
No problem. Yep.
I'm new in this app, by the way.
Great.
Okay. Good morning, everyone, and welcome. I will introduce myself for you. I'm Isra Muhammad El Sisi. Um I'm in Egypt, but I live in Saudi Arabia. So it's this a small mistake. I'm from Egypt. Okay, I'm founder of Lifestyle for You Clinic and also a member of Egyptian Arab Society for Health and Therapeutic Nutrition. Uh, I'm nutritionist, special in cancer nutrition. Okay. Now I'm director of the clinic nutrition department at the Naya Medical Tower in Saudi Arabia for 2 years. I'm founder of Lifestyle for You Clinic in Egypt, and I'm owner of the Gazelle brand for skin and hair product. Anyone guess? We will talk about today about the health nutritional guidelines to prevent colon cancer. And first, we will definition of cancer, and we will definition of colon cancer, and we will know about the incidences of colon cancer around the world and among between women and men, and we will know healthy nutrition guidelines to prevent colon cancer. Next, please. Next. 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 Okay, thank you. Definition of cancer. Cancer is a genetic term for a large group of disease that can affect any part of the body. Other terms used are malignant
నెక్స్ట్
tumors
సర్టిఫికేట్
and
అని చెప్పారు కదా.
neoplasms. One defining factor of cancer is the repeat correction of abnormal cells that grow beyond their unusual boundaries, and which can then invade part of the body and spread to other organ. That later process is referred to the metastasis. Widespread metastasis are the primary cause of the death from cancer. Next, please. Definition of colon cancer. Colorectal cancer is the third most common type of the cancer in pathology. Currently, it's the most common malignant cancer in the gastro, gastrotract, representing 30% of all malignant tumors, and it is considered to the second most common cause of the death related to cancer
ఇప్పుడు లావా
affecting
అంటే ఫారిన్ నేమ్స్.
men and women. Is the same minor worldwide developed the undeveloped countries.
టీనో.
Next, please.
నెక్స్ట్ ప్లీజ్. తెలుసు ఏదో
Now we can see
నేను కూడా ఒకటి అందుకు
the incidence of colon cancer around the world. We will see, and Australia is the bigger than, and Western Europe, South Europe, and North to be the Western Africa. Okay, next. The incidence of cancer among women and men, we will see he is spread bigger than in men's compared to the woman. We will see 149.7 from 10,000 people had a cancer in men, but in women we have 108.4 from 10,000 women. So we can know now this disease is spread fastly in men. Chemicals. Healthy nutritional guidelines to prevent colon cancer as a nutrition focused physical. I recommended the following best strategies to reduce the risk of colon cancer through the diet and lifestyle. Next, please. Prioritize fiber-rich foods. Why? Because the fiber promotes regular bowel movements and reduce exposure to potential carcinogenics. How? Aims for 25 to 35 gram per day includes whole grain, look like oats and quinoa and brown rice, and fruits, look like berries and apple and pears. We can also eat vegetables, look like broccoli and leaf greens. And don't forget the legumes, look like lentils and chickpeas and black beans in my diet. Okay, and limited red and processed meat because he is linked to increase colon cancer risk due to compound like nitrate and
తెలమల ఊపుతుంది
petrolike amines.
రాజశ్రీ గంట
How
వైజ జూలియా
red
ఇది ఒక
meat
అరగంట
should be
హాఫ్
3%
అన్ అవర్ కాదు
3 surface per week, one surface was cooked. Avoid processed meat, pecan or sausage or deli meat, full poultry and fish or plant-based proteins, tofu or tempeh.
వస్తుంది వస్తుంది
Next,
అందరూ అది అందరూ యూఎస్ సార్
don't forget calcium and vitamin D because it's so important. Calcium may protect colon and vitamin C persist immune system function.
శ్రీ విద్య
The
రాజశ్రీ
source
శర్మ
of
ఒక గంట తర్వాత మూడు స్లాట్లు
the
నెక్స్ట్
calcium
మ్యారేజ్
is the
ఫైజ్ అని
low-fat dairy, look like yogurt or cheese, and
ఒక అరగంట
blank milk.
అరగంట తర్వాత ఈ 2+3 ఐస్ లాంటి పెట్టిస్తున్నావా
The sources of vitamin D is the fatty fish, look like salmon and sardines, leafy greens,
ఓకే
and consider supplemented if if deficient. Consult of a health care provider. Next, please. Don't forget the colorful fruits and vegetables. Why? Because she had an antioxidant and phytochemicals combat oxidative stress. We will show focused in a chlorophyll and cabbage, berries and dark leafy greens. Next, please.
Next, please. Maintain healthy weight.
Maintain a healthy weight because the obesity increases inflammation and insulin resistance. So we will management the weight. How? By the balance calories with physical activity and limit sugary drink and refined carb
నీకంటే పాలు
and ultra processed food.
అరగంట బ్రేక్
Next,
అంటే
please.
6:30 6:15
ఇలాంటి కదా తగు పావు గంటలు అయిపోతాయి
Americans అట్లా ఉంటారుగా వాయిన్స్ వదిలి
Moderated alcohol, because excessive alcohol increases a cancer risk. The guidelines say one drink per day for women and two drinks per day for men.
పెడతా
Next, please. Avoid tobacco, because smoking is a risk factor for multiple cancer, including
స్లైడ్ వద్దాం సార్
colon. So be short, avoid tobacco to be stopped it.
ఇంత మాట ఉంది అసలు
We should include it in the diet omega-3 fatty acid, because it's an anti-inflammatory properties.
ఇది మనతోనే
The
మాట్లాడాలి
sources is a fatty fish,
వచ్చి ఇలా మాట్లాడుతుంది
look like salmon and mackerel,
నీకు ఏ టేస్ట్
walnuts and flax seeds, chia seeds.
వాళ్ళు మనకి
Next,
టైప్లో కాకుండా
yes.
ఈపీఎం స్టేట్లో హెల్ప్ చేస్తారు
We should support gut
ఈవెంట్ దగ్గర
health with probiotics.
సాగరి
A healthy microbiome may reduce inflammation. The sources is a yogurt and kefir and kimchi.
నేషనల్ కాన్ఫరెన్స్ సబ్జెక్ట్
Next, please.
నెక్స్ట్ నీ అమ్మాయి చచ్చిందే పెట్టింది స్లైడ్
We
మొత్తం
should be stay
దొరకమండి
hydrated, because the water aids fiber function and designation.
ఆ మూలకి ఇటు ఈ మూలకి
The say from 8 and 10 cups per day water,
హెర్బల్ డాన్స్
included herbal teas.
ఇది నెక్స్ట్
Next, please. Choose healthy cooking methods. Avoid it charring and grilled meat at high temps. Prefer baking and steaming and poaching or slow cooking. Next, please. We should limit it added sugar and refined carbs.
దొంగకుండా కళ్ళు కూడా
Why? Because it's linked to obesity and metabolic defection. We should replace sweet and white bread with a whole fruits and whole grains.
ఈ నెక్స్ట్
Next, please.
నెక్స్ట్ ప్లీజ్ ఆప్ ఫర్ హెల్దీ ఫ్యాట్స్
Opts for healthy fats. We will should choose olive oil or avocado oil or nuts. The limited say saturated fat, fried foods, and fatty cuts of meat and trans fats.
నెక్స్ట్
Next, please. Require screening, complement, and nutrition diet with colon cups, scoops, as recommended, typically starting at age 45.
నెక్స్ట్ ప్లీజ్
Next, please.
నెక్స్ట్ ప్లీజ్
Dietary patterns to consider:
ఎక్కువసేపు పడుతుంది ఎక్కువ లైన్లో ఉంది
Mediterranean diet,
మనం అప్లోడ్ చేస్తాం
చెప్తా
emphasize plant, fish, and healthy fats.
ఓన్లీ యువర్ ఫోర్ హెడ్
Plant-based diet linked to lower cancer risk. Final notes focused on overall dietary patterns.
ఓవరాల్ జ్వరం కూడా చేత కావట్లేదు
The single food combine the guidelines with required physical activity. We should have 115 minutes per week activities for optimal protection. Always consult healthcare provider before making sectional dietary changes. If meaning excite concession.
ZOHO నియమస్యుహెచ్ఓ గారు
Next, please.
నెక్స్ట్ ప్లీజ్
The final. Okay. Finally, thank you for your listen, and I'm so happy and proud to be today for this all audience. And thank you for so much, Mike.
That's great.
And Helix
that's great,
company.
Ashra. That's an excellent presentation, and you gave us a complete food chat. So, what should be taken, what not to be taken to prevent ourselves from falling a prey for the colon cancer. That's really interesting, and sure we are
Oh,
going to
thank
save
you.
this presentation because you gave an excellent information with the food materials, what should be taken and all. So that's really great. And thanks a lot for your time and for an excellent presentation too.
Thank
With this, I just want to give a break for 20 minutes. And meanwhile, I request the people who are there in the panel to participate in the poll. So we have kept some polls. So I just want you guys to poll for us and rate your experiences, so that that will be very encouraging. And you got one more poll is going to start, and so 2 polls for you, and I request you guys to poll. So with this, we have completed almost 8 to 9 speeches for the day, and we have got still more to come. And I request the speakers to take a short break. It's a short and sweet break for 15 to 20 minutes. And then again, we will be back with some new presentations, new speakers, new thoughts. Thank you so much. I'll meet you exactly by 6 and exactly 15 minutes. Thanks a lot. Thank you so much. ఇది ఎందుకు ఇట్లా బ్రేక్ అయింది విజయ్, నాకు అర్థం కాదు.
నా వీడియో వినిపించలేదు వాళ్ళకి, అన్మ్యూట్ చేయగలదా? వీడియో సౌండ్ రావట్లేదు నేను ప్లే చేసేది.
వీడియో సౌండ్ వస్తుంది విజయ్. అలా బ్రేక్స్ ఎందుకు వస్తుంది, స్మూత్గా ఎందుకు లేదు? నెట్వర్క్ ఇష్యూ. ఇప్పటిదాకా లైవ్ వీడియో నాకు క్లీన్గా వస్తాయి.
అరే బయటికి వెళ్ళి కొంచెం బయటికి వెళ్ళి బ్రేక్ తర్వాత స్టార్ట్ అవుతుంది కదా, అప్పుడు రండి అందరూ. అప్పుడు దాకా ఎవరు రావద్దు. మాట్లాడుతున్నాను, మ్యూట్ చేసి వీడియో ప్లే చేయాల్సి వస్తుంది, సౌండ్ రావట్లేదు.
ఓకే చలో సారీ.
చలో గోయింగ్ లైవ్.
సో క్యామ్ ఆపేసి ఇప్పుడు పెట్టండి 15 minutes ప్రొజెక్ట్ చేద్దాం.
పెట్టే నాకు
వచ్చింది ఎప్పుడు మెసేజ్
ప్రదీప్ వచ్చింది నాకు వంశీగారి నుంచి రాలేదు సార్. జస్ట్ ఒక ప్రదీప్ ఒకసారి వంశీతో ప్లెయిన్ పేపర్ మీద బ్రేక్ ఫర్ 15 minutes అని రాయమని చెప్పాను. అదే ఫాస్ట్ ఇచ్చామని చెప్పవా? 15 నిమిషాలు అయిపోతే ఏం లాభం ఇంకాడు.
స్క్రీన్ పెట్టేసి వెళ్ళిపోదాం.
అలా సరే ఇంకా వస్తుంది పర్లేదు.
ఒక వీడియో 15 minutes కంటిన్యూస్గా లూప్ ఉన్న వీడియో ఒకటి, బ్రేక్ ఒకటి, ఇవన్నీ మనం నోట్ చేసుకోవాలి.
రాజశ్రీ సార్ అయిపోయింది. అయిపోయి డిలీట్ చేశాను దీంట్లో.
డిలీట్ చేసి పెన్ డ్రైవ్లో ఉన్నాయి కదా, కన్ఫ్యూజన్ లేకుండా.
అండ్ రాజశ్రీ ఒకటే ఉంది. ఫైజా మనకు ఫైజా ఇప్పించింది. ఇవన్నీ మనం అప్లోడ్ పెట్టేస్తే మనకు ఆ టైం స్క్రీన్ షేరింగ్ అవసరం ఉండదు కదా సార్.
అదే తెల్మా కూడా అయ్యారు కదా.
తెల్మా ఇవ్వాలి
చేయమని తెల్మా.
మీకు ఇప్పుడు ఏంటంటే మీరు యూకే నుంచి యూఎస్ టైం జోన్ వెళ్తున్నాం అంతే.
అలాగే యూకే టైం జోన్ అండి,
యూఎస్ టైం జోన్ వెళ్తున్నాం.
నెక్స్ట్ కూడా అలా బ్రేక్స్ అలాగే ఇచ్చుకోవాలబ్బా. ఎపాక్, ఆ తర్వాత యూరోప్, తర్వాత యూఎస్, ఈ 3 టైమింగ్స్ ఏమండి.
ఫైజా ఉంది దీంట్లో ఎవరుంది? ఫైజా
యాడ్ చేసుకోవాలి.
ఫైజా ఉంది, రాజశ్రీ ఉంది. ఫైజా ఉంది, రాజశ్రీ ఉంది సార్. ఇది ఉంది, ఇది ఉంది. శ్రీ విద్య కావాలి నాకు.
శ్రీ విద్య ఎంత పంపించింది కదా.
శ్రీ విద్య పంపించింది
ఇందాక అన్నారు కదా, శ్రీ విద్య అడిగితే.
శ్రీ విద్య అడిగింది అంతే.
తెల్మా శ్రీ విద్య పంపించింది.
ఇది అప్లోడ్ చేస్తే అయిపోతుంది కదా మనకి.
నేనేం చేయలేదు.
నేను చేస్తాను, చేయలేను కదా నేను కూడా
చేయొచ్చు అనుకుంటా. అప్లోడ్ ఫైల్ చేయొచ్చు.
శ్రీ విద్య, రాజశ్రీ, ఫైజా వీడియో వచ్చింది సార్.
ఏదో ఒకటి అలా పెట్టు. వీడియో ఎందుకు వచ్చింది? ఏం చేసుకుంటుంది అట్లా వదిలేసండి, పెట్టి వదిలేసండి. నాకు పంపిస్తారా? నేను పెడతాను.
అడ్మిన్ నానే ఉంది కదా.
మళ్ళీ మీరు సౌండ్ పెట్టారు, తీయాలి. అది సౌండ్ రాదు. పర్లేదు, మ్యూట్ పెట్టండి, సౌండ్ రాకపోయినా పర్లేదు.
యాడ్ ఆన్ లేదు.
పోస్టింగ్ చేసినప్పుడు ఒక డౌట్ వచ్చింది. మన విజయ్ మీటింగ్లో కూర్చున్నప్పుడు బ్యాక్గ్రౌండ్లో లోగో వస్తుంది అన్నమాట.
పెట్టాం కానీ ఎవరు పెట్టుకోలేకపోతున్నారు. అది
అరే ఒక ఫోటో పడేయమని చెప్తే నువ్వు దాన్ని యాక్ట్ వీడియో పెట్టావురా?
ఎందుకు స్క్రీన్ షేర్ ఎందుకు అట్లా పెట్టారు? స్టాప్ స్క్రీన్ షేర్. లైవ్లో వచ్చేస్తుంది ఇదంతా.
దీన్ని లూప్ పెట్టాలంటే
రిపీట్. ఇప్పుడు 15 minutes బ్రేక్ అలా కనబడుతున్నాను.
ఏంటంటే
లేట్ అవుతుంది కదా.
ఎందుకన్నావా
బ్రేక్ అంటే
ఇక్కడ ఆ కమెంట్స్ అని ఎవరైనా తేడా వస్తే చెప్పడానికి ఒక ఉండాలి కదా.
బ్యాగ్ ప్రీతి ప్లగ్ పెట్టాలి. లేదా చార్జ్ పెట్టుకో పెట్టుకో. ఫోన్ ఛార్జింగ్ సి టైప్ కాదు, నార్మల్ థింగ్. అది ఇస్రాత్ ఒకటే పెట్టా పిక్ రెండు అది స్కార్ఫ్ కట్టుకుంది కదా, అదొకటే పెట్టా పిక్.
అంటే అందులో ఉన్నది కదా, సో పర్లేదు. ఇందాక కొంతమంది వీడియో ఆన్ చేసుకోలేదు, సో వాళ్ళది మాత్రం ముగ్గురే ఉన్నారు.
నేను 2 ఫోన్లు చేస్తున్నాను. 20%
చేయించుకోరా. ఫోన్స్ ఏమైనా ఉంటే సైలెంట్లో పెట్టేసుకోండి. ల్యాప్టాప్ సౌండ్ కానీ ఫోన్స్ కానీ ఏముందండి సైలెంట్లో పెట్టేసుకోండి. తెచ్చుకోండి. ఫోన్స్ ఏమైనా మర్చిపోతే మళ్ళీ వాళ్ళు వస్తారు కదా. వీరేంద్ర ఇది ట్రైన్ తెచ్చావా? వాళ్ళు
ప్రాబ్లం ఏంటి?
తిరిగి ఉందంట, లాగిన్ అయిపోయింది, ప్రెజెంటేషన్ పెట్టేసింది.
నలుగురే ఉన్నారేంటి?
నా స్క్రీన్ షేర్ అవుతుంది. పార్టిసిపెంట్స్ 17.
Yeah, hi, Mike here. So, can we start with the presentation? I need to check once. Once, let me go to it. Right, so you can just share me those. So I'll try to trade here, so it's better because I can control it from here, no? So that should be a better option for you. So let me just go through it. Yeah. Yeah, I got it. Thank you. Yeah. Yes, exactly. Yeah, bye. Yeah. Yep.
రెడీ అంట. వీళ్ళవన్నీ ఇప్పుడు ఏంటంటే నేను ఇది చేయాలి, స్క్రీన్ షేర్ మనం దాంట్లో అప్లోడ్ చేయడం లేదు.
లైవ్ వెళ్తుంది అది. ఎట్లా వస్తుంది?
మ్యూట్లో ఉన్నా నేను.
ఈ చెవులోంచి వినపడుతుందేమో నీకు.
ఉంది సార్.
అది తీసే అయితే వినపడదు, అది తీసే వినపడదు. ఇంకా
నీకు నాకు తప్ప ఇంకెవరికి యాక్సెస్ లేదు కదా.
నువ్వేనా యాక్సెస్ తీసుకున్నాను?
వస్తుందా?
ఇప్పుడు రావట్లేదు.
అది ఈ చెవులోంచి విని చెప్తోంది అంతే.
మళ్ళీ ఈ అతను ఏదో ఒకటి మీద
తెలీదు. ఇప్పుడు లోపల
తీసుకొచ్చి అడదొబ్బే మొహం మీద.
వాయిస్ వచ్చింది, ఇందాక వాయిస్ వచ్చింది.
ఫోన్ 5 seconds ఒకసారి సార్ అప్సల్ అప్పుడే వెళ్ళద్దు.
ఏంటి వీళ్ళే కనిపిస్తారేంటి నాకు? నేను వీఆర్ బ్యాక్ అని చెప్తా.
వద్దు అప్పుడు ఆగండి సార్, పీపీటీస్ రెడీ చేసి మీకు ఎందుకు ఆ టైంలో ఇలా అంటారు మీరు? అవ్వద్దా
వంశీ, దీన్ని మనం పాస్ పెట్టలేమా లైవ్ని?
సార్ ఎవరు లేరు.
ఇంకంతే అంతే.
నేను చెప్పిన పేరు పెట్టుకున్నా.
1 2 3 4 తెల్మా, శ్రీవిద్య, రాజశ్రీ, ఫైజా, ఈ జూలియా
హ్యాండ్ ఓవర్ చేశాడా? చేయలేదు. ఎవరు?
జూలియా. ఆన్లైన్ రమ్మని చెప్పండి.
కాలింగ్ లేదు, ఇది అవైలబుల్గా లేదు. టెల్మా ఉంది కదా, తీసేసుకుంటే అయిపోతుంది.
తెల్మా లైన్గా ఉన్నాయి 2 3.
ఇది కాలింగ్లో ఉంది, రింగింగ్లో
ఎందుకంటే
లేదు.
కంటిన్యూ స్టార్ట్ చేస్తే కంటిన్యూ 5 ఒకటేస్తాం కదా అని ఆగాను. సరే,
అందరూ ల్యాప్టాప్లో ఒకటి వెళ్ళిపోతే ఇక్కడ వదిలేసి వెళ్ళిపోండి, మేము ప్రాబ్లం పెట్టుకుంటాం. లాగిన్ అయిపోయి వదిలేసేయండి. 7:30 వరకు అది ఎక్స్టెండ్ అయింది. ఇక్కడ లేట్ అయితే మీరు అలా వదిలేసి వెళ్ళిపోండి. అది మనకు వర్క్ ఉంటుంది. అది ఇంకా లాగౌట్ అయ్యారంటే కష్టం. ఇప్పుడు వస్తున్న వాళ్ళందరూ మెయిన్ యూఎస్ వాళ్ళు.
ఇప్పుడు యూఎస్
మొత్తం యూఎస్ టైం జోన్లో ఉన్నప్పుడు అందరు వెళ్ళిపోయినారు. ఎపాక్ యూరోప్ వాళ్ళు వెళ్ళిపోయినారు.
1 2 3 4
రిజాల్వ్ అయిందా?
అది అవదమ్మా,
అది అవదమ్మా.
ఎంతమంది? 17 మందా? యానా ఉంది సార్, ఇంకా యానా ఉంది.
ఉందా?
ఫైజా రెడీగా ఉంది. యానా అయిపోయింది ఇందాక ఫస్ట్ లో సెట్.
తెలుసు.
ఫైజా ఉంది.
ఫైజా తీసేసుకుంటా.
ఆగండి ఒకసారి. ఫైజా ఉంది, రాజశ్రీ.
ఫైజాకి రెడీగా ఉందా ప్రెజెంటేషన్? స్టార్ట్ అయిపోతుంది.
ఫైజా తర్వాత సంబంధం తీసుకుంటారా? ఈ 2 స్లాట్లు రెడీ పెట్టుకోండి. ఒక్క నిమిషం ఆగండి. థ్యాంక్ యూ. విషెస్ వస్తున్నాయి.
రాత్రి 12 పెట్టుకుందాం, కూర్చుంటాం కదా, ఎక్కడే ఉంటాం కదా మళ్ళీ. ఏం ఆదిత్య?
ఫోన్ ఇవ్వండి, ఫైజా మెసేజ్ చేస్తాం. బి ఆన్లైన్ వచ్చేయమని చెప్పేస్తాను.
ఫైజానా?
ఫైజా తీసుకుందాం. స్క్రీన్ నాట్ యాక్టివ్ అక్కడే అడుగుతుంది. తెల్మాకి యాక్సెస్ ఇవ్వాలన్నా
ఇస్తాను. లాగిన్ అయిందా?
స్క్రీన్ నాట్ యాక్టివ్
నేను చేస్తా.
సరే చేయండి.
తెల్మా
లివర్పూల్. తెల్మా వచ్చిన వారు లాగండి సార్. ఒకసారి ఆగండి సార్. వీడియో
శ్రీ విజయనారాయణ తెల్మాన్ కాదు, ముందు ఈఎంఐ చేసేస్తాను.
ఫైజా సరే.
రోజీ జాన్ ఫోటో ఉంది కానీ రోజీ జాన్ ఉంది ఇక్కడ.
ఉంటారు సార్.
దీపిక ఎన్ అలాగే ఉంది. దీపిక డానియల్ చేస్తుంది ఎవరు?
దీపిక ఎన్ ఇస్ ఫ్రమ్ నైజీరియా.
డానియల్ ఎవరు? ఎవరా? మీ ఫోటో అయినా
సార్. తెల్మా స్క్రీన్ నాట్ యాక్టివ్ అంట, కొద్దిగా చూడండి.
చేశానబ్బా, వస్తుంది. ఒక్క నిమిషం ఆగు. యాక్టివ్ అవుతుంది. శ్రీ విజయనారాయణ కూడా యాక్టివ్ అవుతుంది. అయిపోయింది, లైవ్ అయిపోయింది. వీళ్ళందరినీ కూడా పర్మిట్ చేస్తాను. టాక్ విత్ ఎవరు మాట్లాడక్కర్లేదు, లేకపోతే కనబడరు వీళ్ళు. అలౌ చేయకపోతే 3 మెంబర్సే కనిపిస్తున్నారు. సోఫియా ఎవరు?
సోఫియా
మీరా? ఓకే. శాంటియాగో
There you go.
మీదా? 2 సార్లు పెట్టారేంటబ్బా?
అది ఫస్ట్ టైం లేకపోతే లాగిన్ అవ్వాలి.
రవికి తెలుసు. రాజశ్రీ ఇంకా మ్యూట్ అని పెట్టే ప్రాబ్లం ఏంటి?
I did.
లారా అలెగ్జాండర్, కాయ్ పార్కరా? ఎవరి కాయ్ పార్కర్?
అదే విచిత్రంగా ఆలోచిస్తే తెలుసా సార్ నిజంగా. ఐ డిడ్ తెల్మా రెడీ నెక్స్ట్ ఫైజా, దాని తర్వాత ఇక శ్రీ విద్య కొడేన్
నువ్వు తీవే దీంట్లో వినిపిస్తుంది, దాంట్లో వినిపించట్లేదు. అన్ని మ్యూట్లో ఉంటే ఎట్లా వినిపిస్తాయి నీకు?
దీపిక నువ్వు ఇయర్ ఫోన్ తీయదుగా, నువ్వు పో బయట.
జాన్ ఏ
ఎత్తుకొచ్చి అడేసావు ఇక్కడ.
జాన్ ఏ
Are you set?
ప్రసాద్ వస్తుందా లేదా చెప్పు ప్రసాద్.
నా పాలని నా మూల కూర్చుంటే
ఇందాక headphone పెట్టుకున్నావుగా.
సరే జోక్స్ పార్ట్ అయిపోయింది.
బైక్
Going live.
వేసుకొచ్చారా?
సార్ దాన్ని సార్ అయిపోతుంది.
ఆగు, డానియల్ వేస్తుంది లాగు చేయని. మన డానియల్ చేయకపోతే ఎట్లా?
సార్ చెప్పండి, అందరం ఉన్నాం. ఒక్కడే కాదు.
రాజేష్ అయ్యంగారు కూడా ఏంటిదే ఈయన ఇప్పుడు ఇంకా చచ్చినాయి. ఇంతసేపు అవుతుంది యాక్టివ్ అయ్యేందుకు అందరివి. అమ్మ మీకు యాక్టివ్ పెట్టాను, మీరు ఓకే కొట్టాలి, లేకపోతే యాక్టివ్ అవ్వదు. నన్ను కాదు, దాన్ని యాక్టివ్ చేయండి. we can hear you అని వచ్చింది.
థ్యాంక్ యూ సో మచ్.
Okay.
మందువానా? ఎవరు? జాన్ ముందువా? ఎవరు?
ఎవరు?
నువ్వా? నీ పేరు కూడా పెట్టి నీది యాక్టివ్ చేశాను.
Can't see anything. Can't
Okay,
see
go.
any slides, anything.
ఓకే. ఈ ముందువా జాన్ ముందువా?
I'm waiting for the first slide to go up there.
వెరీ నైస్. సో ఆల్ ఆర్ అవైలబుల్.
సార్ ఒక మాట చెప్పనా, మీరు ఇంట్రడక్షన్ అయితే మాడేమంటారు అడుగుతుంది తెలమా.
అందే
క్యాన్ ఐ బిగిన్ అట్
ఏంటబ్బా గుడ్డు 2 వచ్చినాయంటే ఎవరు పెట్టారు గుడ్లు?
ఏ గుడ్లు?
గుడ్లు 2 వచ్చినాయి పోల్లో. ఫోన్లో బ్యాడ్ రాలే అంతవరకు.
అప్పుడప్పుడు ఇంకా బ్యాడ్ రాదు సార్. ఇంకేమొచ్చింది చూడండి, ఈ కింద లాస్ట్ క్వశ్చన్కి ఏమొచ్చింది?
విల్ యూ సజెస్ట్ హెలిక్స్ అంటే 100% పెట్టారబ్బా.
కాదు, లాస్ట్ క్వశ్చన్కి అదే నాకు వచ్చింది.
వెరీ గుడ్.
లైవ్ లో ఉంది ఇప్పుడు.
లైవ్ లో
ఉంది, నేను మ్యూట్ లో ఉన్నా. యూట్యూబ్ లైవ్ లో ఉంది అంతా.
ఇవన్నీ కనపడుతుంది. నేను
వెళ్ళిపోండి లైవ్ లో.
ఫస్ట్ దీని మొహం వచ్చింది. యూట్యూబ్ లో ఉన్నా ఇప్పుడు.
మీకు యాక్సెస్ లేదా సార్ మొహం తీసేయడానికి?
లేదు, మొహాలు తీసేయలేము.
రిమూవ్ అడ్మీ తీసేయండి.
ఓకే, ఐఎమ్ స్టార్టింగ్. ఎవరు తెల్మానా? ఎవరు వీడియో పెట్టాలి కదా? ఉందా?
ఫస్ట్ ఇంట్రడక్షన్ అయిపోయింది.
ఇంట్రడక్షన్ అయిపోయింది.
ఇంట్రడక్షన్ అయిపోయిన తర్వాత చెప్పండి.
Yeah, hi. Welcome back all. So, I guess you have done tea time or a tea break for 15 minutes. So we are going to start with the session now, and I'm happy like eminent people are now with us, and so I am going to invite Delma Liverpool, and she is from South America, Guyana, and she's a graduate from Howard University, USA, and she earned a bachelor degree and master in arts in chemistry. and she began her professional career as a scientist at DuPont company, Delaware, and now she served even as a senior specialist and a consultant in safety, health, and environmental affairs. So she's back to US after completion of her courses and all, and now she's an entrepreneur. And since 2018, or in 2018, she became the president of Tiny Holding Corporation, and her company is now dedicated to develop innovative devices designed to assist and care bedridden individuals. So it's a really great part, and she's working for this organization with this innovative devices for the people who are bedridden. That's a great part, Thelma. I'm very happy with that. And prior to that, with the introduction part, I just want to have a video of Thelma, because more than words, the video tells you a lot. So I just want to play the video now, and after that is completed, then we can go ahead with the presentation. Yeah, video please. That's a fantastic video. We could see a lot the products of the company, and how actually they assess the people, that we could understand by the video. That's really great, Thelma. So now that's all yours now, and you can start with your presentation.
Okay. Thank you very much for the introduction. Good afternoon, good morning. As I said, our company is essentially working on innovations to help with people who are bedridden. The information I will give you is essentially drawn from the U.S. population, because I know that the problem of elder care is worldwide, but I will focus on the U.S. at the moment. Could I have the first slide, please?
So I just want to wait for the 5 to 10 minutes because there might be some technical issue from Thelma's end, so I just want to wait for that. So by the time, Thelma, can you just plan for your things, like we are waiting for the presentation?
Okay.
Then voice రావట్లే and రావట్లే.
కానీ ఉంది మాట్లాడుతుంది సార్.
Voice రావట్లే.
Yeah, I can just say a little bit more about caregiving. Caregiving, I know, is different in every country. It depends on the culture, it depends on society, it depends on family structure, etc. But it's different for every country that I've lived in. I've lived in South Africa, I've lived in Guyana, I've lived in the US, and I see the patterns of caregiving as I grew up. So at this point, it is very expensive from what I observe. Families usually have to hire someone to help them or have to learn how to do things with bedridden people. It changes the dynamics in a family. So I think our device will be helpful in alleviating some of the pain from taking care of people.
Okay, so can we go ahead with your presentation? We're just waiting for it.
Yes, I'm waiting for your slides. I want to use the slides for help.
Right. I'll share it. I'll share it. Yeah.
Okay,
Sorry,
great. Thank you.
for the delay. Yeah, it's done now.
There we go.
Yeah, please go ahead. Please go
All
ahead.
right. Here I am. Next slide, please. The next slide shows the among the numbers by number, the population of aging people over 65 in every country, not every country, but in about 50 countries. The US is way down at number 34. But our system, again, has proved to be extremely expensive and very demanding for families. So the numbers I quote are from all United States documentation. The next slide, please. Let's see. All right. This is very small. Could you expand the? Could you expand the slide, please? It's very tiny. It's like trying to read that.
Yeah,
But,
we are doing it. We are doing it. Yeah.
Okay. So other people can read expansion. Yeah. Okay.
Can you read now? Is it fine
Yes,
with you?
I can read that. Yes, that's fine.
Great.
Okay, so the state of aging in the U.S. Is that by 2040, there will be 81 million Americans who are 65 years of age or older. As we know, people are living longer because of better medical care. And so there is, as we can foresee, an increased need for ongoing care, which means as people become bedridden, they may last a lot longer than we expect. And a lot of people are living now to age of 100, et cetera. But, that is all because of better care, et cetera, better medical care. Other categories of people who need care and who become bedridden are special needs children. And there are also short-term needs for bed care for people who have accidents or who become ill. Okay, so the current issues are, my concern is for the patient, but also for the caregiver. The caregivers in America are unpaid. And at the moment, the Association for American Retired Persons estimates that there are 100 million people who provide care for people who are bedridden. And they are unpaid. They fall into the sandwich generation, which is they have their own families and they're also taking care of an elderly person. They are spouses, and the genesis of my whole research was that I lived with an elderly couple, and to see what this elderly woman went through in taking care of her husband, who now is like a baby, who's 6 feet tall and 200 pounds. And that spurred something in me and said, no, this has to change. So these are spouses, they may be at any age. Some are parents who are taking care of children, and they at some point bring in all family members that they can. They're working couples. Now imagine the couple in the sandwich generation who have their own families to take care of, plus now they have to take care of the elderly person, and they're single parents. And there are grandchildren who get involved. I've seen pictures of grandchildren helping to take care of their grandparents, and even friends and neighbors are involved. So it's a very wide net that is spread, and this 100 million currently involved people. You can see this becoming larger as the population of aged becomes greater. Next slide, please. Okay, the aging sector is now a growth market, which means that it is attracting investment, it is attracting entrepreneurs, it's attracting innovations, etc. And we are all aware of the influx of smart toilets that can actually diagnose illness based on the urine, etc. We have smart beds. There's a lot of gadgetry that are new that nurses use rather than just the old-fashioned way of testing things. There's a lot of gadgetry, smart watches, etc. More current is the use of robotics, where we can actually think of robotic nurses and nurses helping to do the lifting, etc., and doing things. And so because of electronics, you can now have remote personnel, doctors in their offices, talking to patients at home, and a lot of virtual services, etc. So my innovation is just one more in a string of new things that are out there to help the patients. So what is currently acceptable or preferable by many people is aging in place. And aging in place means you stay in your home, you have people come in to help you, or you live with your family. And this is, your options are very few. You go to an institution, or you stay at home, or you go to some kind of facility, or your people can hire someone to come and stay with you and live with you. But the advantage of aging, would you lift the slide, please? Could you lift it up, please? Could you lift the slide, please? Yes, thank you. Aging in place, again, is by choice or dictated by economics. Many families are not in financial position to either hire someone or to put someone in an institution. And we know the prices of these institutions are increasing daily. The current price you can hear are $150,000 a year, and for a really top class situation, you have to pay a lot more than that. So the advantages are to stay at home, and at home we know that you have people. If you lived in the house forever, you have a routine. You may have had a bath before bed every night. You may have had a shower after you exercised or went for a walk. And what we aim to do with our invention is that you can continue this, that you can have a bath in bed. We have patented our inventions to allow you to have a bath in bed. So this is a routine that you can continue to have even after you become bedridden. And it will bring a sense of normalcy, I can still have my bath, I can still have my shower. So this is familiar. It also helps with the interaction with family members or with caregivers, because you can reminisce about, I remember you going to church and having this scent on you. I remember you walking with me and holding my hand and all of these things. So being at home with family to take care of you, I think in some way gives some comfort and some continuation to the patients. The disadvantages are many, and primarily for the caregiver. You can imagine having to work for an entire day, be in constant call if something happens to someone at home, and having sometimes to take time off from work. sometimes to leave work in the middle of something that you're doing. And so the sacrifice of the caregivers begins to affect their own jobs and their own positions. And the time spent in full-time caregiving is almost another 8-hour job. It's a full-time job. It is not just, seeing them go to bed or changing their diapers or whatever. So it's a full-time physical job because the patient has to be lifted to the bathroom, lifted into a hoist, then into a wheelchair, then into a bath chair, and back again. And this is time-consuming and difficult. And we all have heard stories of patients who have had slips or falls. And we know that in an older patient, having a fall is very, very dangerous. Within a year, many people die from the results of falling. So with our invention, we hope to avoid that situation. The caregiver medicine, it's cleaning a person, changing diapers, doing all the things, feeding them in some cases. In some cases, they are fed by tubes to make sure things are clean. And it's a very complicated job. So the physical labor required in taking care of a patient, especially for bathing and toileting, is known. It is known. And so our innovation, again, the innovation is what you saw in the video. It will help a person to have a BM in bed. We have tried to make the device as simple as possible. It will not be in contact with the patient. Once it is on the mattress, once it is inserted in the bed and it rests on the mattress, but it also your mattress protector will cover it. Because what we have done, we have designed the special mattress protectors that will have a lead-in into the enclosure. So the person will never be in touch with the device. On top of the mattress protector, you put your regular linen, and so the person, and of course they are cut out so that the hole is there for the person to have a BM, etc. And we have also gone another step to design the kind of clothing a person would wear if they are on this bed. Now, the normal thing is to have a diaper. A diaper becomes damp, it becomes wet, it becomes soiled, and this is in contact with the skin. We know that bed sores are a big issue. So what we have designed is clothing that will is very thin, for one. The second case, if you have urine, it will drain into the enclosure, and the fabric will either dry or be removed by an attendant, so it does not stay, the wetness does not stay around the person. Okay, and so that is another step we've taken. Next slide, please. The name of our product is going to be AIDS Pro, and we have got a prototype of the system, which I'll show it to you in another slide. But the prototype will give you an idea of how it operates. Next slide, please. Okay, so this is the idea. This is an example of what it is. We have talked to and had communication with the National Institute of Aging and with the National Institute of Health and Human Services. So this is what we envision a person in that bed with the device will look like. The device itself is shown in the second picture. You can see that the top part, the black part, is what rests on the bed. The flexible part is under the bed, which means that the container can be pulled out to be seen. In the prototype, the container is opaque, but in when we have our final product, it will be transparent so that you can see that the remote person will be able to see what is inside of the container. We think that the amount of material, the state of the material, is it running or is it solid? The frequency, there's actually a measure telling you, if there's a temperature difference, or if the length of time that it took to accumulate to this level. The caregiver can take a sample out of there. There's an entrance for an equipment to remove samples if needed, and so we think that this container has a vital role to play. It also has an exit point where we can hook up an odor control system, and we are working on that as well. And how do you control the odor in a room when this is going on? We also figure out that at night, the size of the container can change so that the caregiver gets some rest, that they don't have to be up all night checking every couple of hours to see if it is full or not, if it is large enough for the patient to use at night. We all are aware that during Ebola, any contact with that waste was a death sentence. Pretty much, you got the disease. So what we think this container will do is prevent contact with infected waste, which is another safeguard for the caregiver. Okay, we have received a patent for this innovation. We have also received a patent in Korea and Japan. We have also filed in Europe, China, India, Brazil, and we also are in Canada. We also have a patent in Canada. So we have tried to protect our IP as much as possible, and we are very happy that this will be at some point on the market. We are currently working to that end. So we are looking to be at trade shows and other venues, which will make people more aware of what we're doing. Okay, next slide, please. Yeah, this is just a little virtual picture of what the person will look like in place toileting. Again, as we said, there is no relocation. And we know that, of course, the dangers of relocation, the patient may be in pain. They may be really not feeling well, and they have to be hoisted and lifted and increasing their discomfort, increasing the pain. So we try to alleviate that part of it. We also look at the time saved, that the time it takes to go to set the person up, to go to the bathroom. You're looking at a good half an hour, and time is critical to the caregivers. They really don't have a lot of time. They just forcing getting all these issues done. But what we've done here again is cut down on the time, excuse me, on the time used to do the relocation and bringing them back. We also will prevent a lot of the use of the diapers. I have seen, again, as the diapers accumulate and are put into waste systems, and I imagine all of those diapers from so many streams, so many homes, so many facilities being sent into the environment, because they are. I don't think they're burned. They may be. I'm not aware of that. But if it goes into the environment, we have an issue of small animals getting to this. We have an issue with the rainfall, the waste goes into the water system, in the water table, and that recycles into our water stream. So the impact on the environment, I think, from reduced use of adult diapers is an issue that I think of primarily because I was an environmental specialist. As I said before, slips and falls are averted. there's an enclosure that is from, in the second picture, this is not the actual enclosure. There are enclosures, there are 3 types of enclosures that have been invented, that we have patented, that will fit in the bed. So even if a room is occupied and a patient has to have his bath, you can form an enclosure, they have privacy, and they can have their shower, they have their bath. To have a bath, you simply plug the exit and fill up the bath with water, and fill it up with water, as much water as you need, and that will form a bath. If you want a shower, simply let the water flow, and the person can have a shower in bed. Everyone is aware, all nurses I know are trained on removing bedding and adding, while the patient is in bed still, and you don't have to remove them. So the same thing goes here. You remove the bedding, you form the enclosure, the patient has their bath, you put the bedding back, and your system you're set to go. So it's a very tight process, and I think it's very helpful to individuals. Next, please. Yeah, these are some of the issues that we are looking at. I'm going to try to read them. I don't know if I can read them all, but we have short-term illness, long-term illness. Let's see here, home care, institutional care, and I can't read it. We have care of people in hospice, and you also have now adult daycares. So at adult daycares, you can imagine that this system is set up directly to interact with their toilets. And so when the patient uses the system, it's not being collected by a caregiver or by an attendant, but it can be set up to go directly to the toilet, so that the amount of time spent in cleaning up is decreased. To clean the patient themselves, it's a matter of turning them on their side, because of course they're wearing special clothing that allows the buttocks to be exposed, and so there's no spreading of waste, feces on the body itself. So to clean the patient, you simply turn them on the side, clean them up, wipe their body off in a nice, soft, clean towel, damp towel, and they're ready to go. So you alleviate a lot of things to do with the skin, and the skin interacting with feces and with urine. So I think this is an ideal system to help in the care of these individuals. Next, please. Yeah, the intellectual property I've just discussed. We have done as much patenting as we can. Of course, the competition will not stop. There will be other innovations, but we think right now we can work in tandem with, or be absorbed by some of these current companies who are diaper producers, who are smart toilets, who have all of these other devices, and we see ourselves as partners rather than competitors, because but we want to make money. That's the bottom line. But we will continue to have other devices as we proceed. Our company, and I'm remiss if I do not mention the names of my partners. I work with my team, and they consist of Dr. Darlene Dixon, Dr. Shirley Kablan. Our AI person is Pablo Alvarez, who owns his own company, and our secretary is Mrs. Kim Ray. So these are partners, these are the people I work with, and they are very, very good at what they do. So I'm particularly grateful for their assistance. Next slide, please. These are the advantages I see for the patient. The painful relocations are avoided. This collecting of samples is easier. Sample authentication is assured. There is no doubt as to whose sample you're testing. The encasement in damp soil diapers for uncertain periods of time is avoided, because we've heard horror stories of people being left unattended for hours at a time. Of course, this, of course, has to do with the bed sores. And then think of a similarly modified wheelchair, that a person can be put on a wheelchair that has this device on it and be taken for a walk. They can go sit outside under a tree and do their business if they have to, and then they're brought back inside. So it will allow some kind of movement of individuals. You also think of transport. If these systems are, and they are portable, they're portable versions of the system, that they can be put in a back seat. The person can lie on that bed, on that system, and go on a trip, a short trip, a long trip maybe. We can also see them in emergency vehicles, so that the patient can be transported, even if they're having maybe a running diarrhea or something of that kind occurring. And sense of normalcy. You're having a shower, you're having a bath, and you feel good about that. And the interactions with your caregiver is less stressful. And so again, for the caregiver and for the patient, the prevention of falls is important, because caregivers do fall. They can fall and they can slip, they can have accidents. Many of caregivers complain of back pain because of lifting, so the benefit is to them. So there's no physical lifting of the patient. There's ease of cleanup following toileting, less time spent in toileting and bathing, which are routine activities. The calmer interactions, their sample collections are enhanced, protection from infectious disease, and notification of movement. There is a future state where if there's a bowel movement happening or someone is passing urine, you can have a sensor that will tell you this is happening. So if you need to collect the sample very quickly, or you need to do something, you can leave what you're doing, because you know this is going on. So this is something else that can happen in the future. For the environment, we see that there are fewer soil diapers released to the environment, which will help with our environmental situation and keep us a little safer and keep our water purer. So this is the end of my presentation. I thank you for your attention, and if you have any questions, I'll be happy to answer.
That's really excellent presentation, and I just want to ask you one thing, Telma, here, like, why didn't you keep these exhibits and some conferences and all? See, because your product is very unique and it's very useful for the people who are really bedridden, and I just want to understand, like, how many countries you are in, and to how many exhibitions or conferences you have exhibited these products.
We are a very tiny company. We do not have the budget for international travel.
Don't say that, because the products are really unique. You can't say the tiny company. The products which you have are really they're very advantageous, right? So I just want to offer you one thing here, because we have got a conference in Valencia, November. So I'm expecting you to be there at the conference with your exhibits.
I will do my very best to be there. We are now getting having smaller samples made. We're smaller that you can take in a suitcase and exhibit somewhere. So that's the plan. The plan is now to make
Great. So I'm expecting that to happen in October, and you will be coming to Valencia by November with all your exhibits. So I want to see you there because it's really interesting, and obviously this is very much useful for the people. So that should come out. So Helix is going to give a very good platform to exhibit your products there at Valencia. So I'm just waiting for you there at in November 25.
You'll be waiting at the airport, right?
That sounds great. I'll definitely come for you there.
Thank you so much. I appreciate the opportunity.
Yeah, great.
Thank you.
So that's an excellent speech and very informative too. Thanks a lot for your speech. And
Thank you.
let me move on to the other person. So it's Dr. Rajeshri Iyengar. She's from. She has got an scientist position. She is a scientist in Indian Council of Medical Research from Bangalore, and she has done her master's in public health and a distinction from University of Dundee, Scotland. That's really great. And she has got an academic background which includes the undergraduation in dentistry, and she is even awarded with a gold medal in the pediatric dentistry. That sounds really great. So I just want Rajeshri to take over, and we are waiting for her speech.
Yes. Hi everybody. Am I audible and visible to everyone?
Yeah.
Yes.
Okay, perfect. At the outset, I'd like to thank Thelma for that very thoughtful presentation.
Thank you.
I've been caring for my grandmom, and I saw so much of that in your presentation. So if these products were here in India, it would have made a difference to so many. So thank you for that thoughtful gesture.
You're very welcome.
Okay, and thank you to the organizers at Helix for having me today. I'd like to begin by saying that in my presentation today, I will not be representing any of the organizations that I'm affiliated with. This is rather, it's like a scientific dialogue for me with the global community in my personal capacity. So yes, thank you for that wonderful introduction as well.
Yeah, that sounds really great. And we are going to present your slides, and you can just go ahead with the presentation. We are going to assist you with that.
Yeah, perfect. Thank you so much.
Yeah.
Yes, there it is. Thank you. So what I'm going to talk about today is a very pressing issue across the world, which is genetic disorders. I'd like to begin with a quote from Sam, a writer from America, who says that genes are like the story and DNA is the language in which the stories are written. So we'll discuss more about DNA, the genetic disorders, the prevalence across the globe, and in India as well, from where I belong. And thereafter, look at some ethical consideration. At the moment, I'm working in the area of ethics. As mentioned in my introduction, I have a background in dentistry for my undergraduation and public health thereafter from Scotland for my master's, where I worked with some homeless people in Edinburgh for the Smile for Life program. And at the moment, I'm working in bioethics. So I would also discuss some ethical aspects in this presentation. So can we please go ahead to the next slide? So over the next 30 minutes, we'll be discussing and going over genetic disorders, an overview of genetic testing, some ethical considerations, like I mentioned, something very important, communication with the participants through genetic counseling, social implications of genetic research, some future directions, and finally the conclusion. Can we go to the next slide, please? So like I quoted earlier, genetic disorders stem from DNA, deoxyribonucleic acid, and its abnormalities, which could lead to diverse health issues. The issue with genetic disorders are that they can pass through families because they're inherited or result from new mutations, which directly may impact the bodily functions. Millions of people are affected globally, and there is a significant healthcare burden due to genetic disorders across the globe. Now, ethical considerations are extremely important in these genetic disorders and the research associated with them, as we will see in the forthcoming slides. There is a strong need for public awareness of these disorders. There are a lot of patient advocacy groups and patient representatives that I meet often who are really trying hard and trying their best to spread awareness about different types of genetic disorders because they really impact the quality of life and productivity. So let us please move on to the next slide. Here's a study from 2004 which presents the minimum global estimates of the birth prevalence of genetically determined congenital disorders, but this is categorized by economic levels. So if you look at the graphs, you can clearly observe a trend. So the total burden is at least 20% higher in the low resource countries. So if you could see the low income countries, that's the highest bar. So it's at least 20% higher when compared to the high resource countries. So there's a clear economic disparity here. So this data is actually from a study by Christensen Arnold. Although it's a really old study, 2004, I think we've still got a lot of opportunity to improve and reduce this health gap. Let's move on to the next slide, please. So given that economic disparity, let's now look at the global prevalence. I've put a slide for rare diseases because the statistics are staggering. There are approximately 300 million people across the globe who are living with rare diseases. And around 80% of these rare diseases have a genetic cause. And 70% of these present in childhood, which means the quality of life is very strongly impacted for people with genetic disorders. And 95% of these rare diseases do not have approved treatments. For a person to get an accurate diagnosis that they have a genetic disorder, the time period is just staggering. It could take about 5 years nearly for a person to even know that they have a genetic disorder, which is rare. And 30% of the children with these rare diseases unfortunately meet their death before they even turn 5. So this is an area that really has to get prioritized when we are setting our priorities for research. Can we go to the next slide, please? So we did see the global prevalence of rare diseases, but when it comes to India, the records are staggering because across the world, across Europe, UK, America, Africa, when we compare the highest number of prevalence, the highest prevalence of rare diseases is in India. It's 72 million people that are affected by rare diseases. And in the ICMR registry, as of September 2024, there are 14,000 cases registered in the rare disease registry, but I'm sure there are much more that the registry has to account for. So this is an area that really requires awareness, prioritization, and scrutiny and engagement from researchers, from patients and public advocates, representatives, and all of us around the world. So let's go on to the next slide, please. Now let's move to genetic testing. Like I said, it could really take nearly 5 years for these rare diseases to be diagnosed. And these have to be diagnosed through genetic tests most of the time. So let's see what genetic testing is. So there's 3 types here: diagnostic, carrier, and predictive testing. The benefits of genetic testing is that it could facilitate early diagnosis, precision medicine and personalized treatment, and of course, prevention strategies for members who could be affected in the family later. So potential risks of genetic testing are of great ethical concern because it not just affects the person themselves, but there could be implications for the immediate family, friends and relatives. So there could be anxiety from results, like I said, implications for family, and a limited access based on economic status. These tests are generally not inexpensive. People have to burn a hole out of their pocket to really get it tested even. So that's the ground reality for many of these genetic diseases. Can we go to the next slide, please? So these genetic testing and screening would be able to reveal information about how likely an individual or members of his family are to be carriers of genetic defects. So carrier is a person who has a gene that could cause the disease, but does not have the disease himself. So this person could carry this disease and transmit it to the children and grandchildren and so on, but they themselves are not affected by the disease. So you could find out if a person is a carrier, or you can predict if a person may get a disease in the future. So these genetic tests and screening tests are quite useful. There are some rules and exceptions here as to what kind of information of the results that we get out of genetic tests can be shared. So an individual's genetic data is very unique. It's like a fingerprint. There are techniques called DNA fingerprinting, because every person's DNA is unique. So an individual's genetic data cannot be shared with the family members without getting explicit consent from the person. So the person has to be fully informed that they are going to be tested, and the results shall be shared with his or her family or friends with a full consent from the concerned persons themselves. So without consent, the results really can't be shared even with the family, unless it is deemed necessary to help the person survive, or we're looking at ethical principles. If the person will be benefited by sharing the results, only then. But you most definitely require consent. So there is a strong need to counsel people, because a lot of them are not aware of what genetic diseases are, how they develop it, who are carriers, who can transmit the disease. So genetic counseling plays a very important part, and it's important to alleviate their anxiety as well. Now, like I was saying, the results could be disclosed only if the consent from the affected family member is obtained already, or it is required to save his life or prevent harm. And if consent is refused, the risks of non-disclosure versus a breach of confidentiality have to be weighed very carefully, and a decision is taken accordingly. So that was about genetic testing, counseling, exceptions for consent. Can we go to the next slide, please? Thank you. This is much of what we already discussed, so I'm going to go through this quickly. We need the results to be communicated, especially more than harm. If there is a chance of benefits for the people by knowing the results, definitely should be communicated. Whether good or bad, the results should be communicated with the concerned person. And this should be specified clearly in the informed consent document. Now, informed consent document consists of two aspects. We've got the informed consent form, where the person's consent is obtained, and also it consists of a participant's information sheet, where this patient or participant is given full details of the study in a very comprehensible, simple, plain language, so that they can read through it, get to know, understand. And there must be provisions if they are illiterate, especially when we're considering the global south and the low and middle income countries. There has to be provisions for that, so that the patient or participant is actually fully informed before they consent for anything. So information is paramount, and the ethics committees generally work with researchers. For those among the audience who don't understand these terminologies, please hold tight. and hang with me as I will let you know. So ethics committees are actually like gatekeepers who look at research proposals to see whether this research is actually meaningful, will actually have a social impact, will really benefit the participants. So the ethics committees give their approval to researchers, even for the return of results when it comes to genetic testing. And like I said, DNA is very unique to every person. So identifiable information is invariably present when it comes to genetics. So samples should be anonymized or de-identified to protect the privacy and confidentiality of participants. But results cannot be returned from samples that have been irreversibly delinked from the personal identifiers or anonymized. So that's another concern. Can we go to the next slide, please? Now, ethical considerations are extremely important. I've already touched upon some of them: informed consent, privacy, and confidentiality. But what is ethics really? Ethics is about making a moral decision whether something is really benefiting people, society, and whether the benefits outweigh the risks. So in simple understanding, ethics can be thought of like this. We'll see some basics of ethics over the next few slides. Can I go to the next slide, please? So there are four basic principles of ethics, core ethical principles, which include autonomy, beneficence, non-maleficence, and justice. So autonomy is giving the rights and respecting patients and participants for who they are, ensuring that the individual's autonomy, ability to make their own decisions, is protected throughout the process of research or treatment, ensuring that these participants come to the research study voluntarily, and when they are vulnerable for exploitation, there are special safeguards to protect them, right? So all of this comes under autonomy, and informed consent as well. They should be fully informed before making an informed decision to participate in research or undergo treatment. Beneficence is that whatever we are trying to do as researchers, physicians, should be intending to maximize the potential benefits for individuals and society while striving to do good. And the same goes for non-maleficence. We want to minimize the potential harms and risks to the participants and patients. Justice is something that we're all really working hard on. Like I said, there is clear economic disparity, but we try and make sure that there is a fair distribution of benefits and burdens of research so that there could be equitable access and treatment for all. This is something that we're really trying to work on, and we can do it together. So can we go into the next slide, please? Right. So nature of harms and risks have to be weighed. For if you're a researcher, or even if you're not a researcher but plan to do something that benefits people, it's important that we plan about what could be the risks, what could be the harms, what could be the benefits, and try and strategically make plans so that the benefits can outweigh the risks, and only then do we undertake any kind of research or study. So we have to weigh the social implications, see if the privacy and confidentiality is protected, think of future consequences, think of emerging technologies that could have an effect in the future, and how any issues that arise can be mitigated. The ethics committee as well. Now, ethics committees have diverse group of people, but they may not necessarily know or be experts in the area of your research or specialization. So ethics committees have a group of people who may not be experts, and they might need to sometimes co-opt or bring in subject matter experts so that they can really evaluate your research proposal correctly and fairly. So we must also think of a collaborative approach and safeguards for vulnerable population. There is another thing called therapeutic misconception. A lot of times, clinicians are also researchers. I've been a clinician researcher before, and now I'm a full-time researcher. So what happens is clinicians often have patients who enroll as research participants. So the patient of this clinician is now a research participant. The patient may not know that they are actually participating in research. They are still thinking that, oh, it's their doctor just giving them standard treatment. Mm-hmm. So that is called therapeutic misconception. We don't want people to be misinterpreting things or assuming that they are receiving standard treatment while they're actually part of research, right? So there has to be, that's why the informed consent is very, very important. And people must be fully informed of whether they're being administered treatment or whether they're being given, treatment as part of research, right? Can we please go to the next slide? Right. Written informed consent is essential because when things are documented, they are concrete. So consenting for screening and subsequent confirmatory test does not imply the consent to any specific treatment, termination of pregnancy. While what this point is trying to say is that if somebody has consented for a diagnostic test or screening, it does not mean that they have consented to undergo any specific treatment or things like termination of pregnancy for research. So informed consent is very clear, must be very clear in what it seeks. And if children are being involved in research, there's the concept of age-specific assent. And I'd be very happy to discuss this further on emails if any of you are interested. Can we go to the next slide, please? Now, when somebody is diagnosed with a genetic disorder, it's very, very important that they're not stigmatized, discriminated, and they themselves fully understand what's going on. So genetic counselors play a very important and key role in such cases. They're going to act as liaisons, provide guidance and support, and educate the patients. They also help people interpret results in the personal or familiar contexts, because genetic disorders could affect the family, like I said, they could be hereditary. Now, counselors again must prioritize patient autonomy and decision making and be prepared to have difficult conversations. They also offer emotional and social support to patients and families who are coping with such test outcomes and risk discussions. So can we go to the next slide, please? So the genetic testing and research team, the role of the team is that they must create awareness, and this is a multidisciplinary team, and the team should consist of qualified lab personnel, physicians, counselors, counselors with formal qualifications, and specialists who deal with genetic disorders, who are trained in genetic counseling, are part of this team. It's essential so that people get the right information. Can we go to the next slide? Now, genetic research could influence public health policies, directing resources for prevention and screenings. There is a huge gap in access to genetic testing because many of these tests are quite expensive, and there is an economic divide here. But ethics always pushes for people centricity in research and equity. So as far as we can, we want to try that all individuals have access to genetic services and get unbiased care. So can we go to the next slide, please? Now, the thing with genetic research and tests is that there is a lot of scope for misuse. Mm-hmm. So there are regulations across the globe already, and some of which are in India as well. So because there is prevalence of female feticide in several parts of India, the prenatal sex determination and sex selection of the fetus is not allowed. HLA testing on embryos and fetuses is not allowed. Eugenic genetic engineering called the designer babies, where you could select the eye color, the hair color, the skin color of the child,
Yeah.
predetermine it, is actually raises a lot of ethical questions. Is it even okay? So that is not really allowed. Germline therapy in utero gene therapy is not allowed. Some of these terminologies are technical, and I would ask you all not to worry too much about it at this stage. So can we go to the next slide, please? So I come from the global south, and I'm sure a lot of fellow speakers and the audience would resonate with me when I say that low and middle income countries face quite a lot of challenges that are different from the high income countries. We have limited resources, infrastructure deficits, lack of trained professionals, especially when it comes to genetic testing. So this inherently makes people in the global south with low resources more vulnerable compared to those elsewhere. So making equitable access is critical. And it's only possible if we all work together for this as a global community. Additionally, we've also got some cultural beliefs and stigma, which will influence perceptions and responses to genetic testing. So we have to really be culturally sensitive when we're trying to deal with genetic disorders. Can I request the next slide, please? Now we've already got newer technologies. The future is here. So emerging technologies like CRISPR-Cas9 and artificial intelligence and genomics are raising newer ethical concerns. For example, AI, like who is accountable for the decisions that are made by artificial intelligence or recommendations? So there is no single person that could be held accountable, which is a big concern. And regulatory frameworks are needed to keep pace with such advancements so that we really protect people while we are also embracing innovation. Public engagement, education, and awareness is very, very, very important for informed citizenry and to advocate for ethical standards that align with the values of the global community. Can we go to the next slide, please? So that's the end of my presentation. It has spanned various areas: genetic counseling, ethics, genetic disorders, rare diseases. But what I really want to do here is actually to kind of begin a dialogue again among the scientific community to create awareness about these disorders. We want to understand genetic disorders, the testing, the ethical implications that they have. And this is to just rekindle an ongoing dialogue among all the stakeholders and champion ethical practices in genetic research testing. While we prioritize people's rights, people-centric research, and try and push for equitable access of genetic testing treatments and access to information for everyone. So that's about my presentation. Thank you all very much for listening to me patiently. My email is on your screen if you have any questions at all. So can you please go to the next slide that displays my email, please? Thank you very much once again, and I extend my thanks to the organizers once again for this wonderful opportunity. I really resonated with the presentations throughout the day, and I'm appreciative of the fact that women and areas that matter to women have been discussed today. I really appreciate that. So I'm also putting up my recent publication and my email in the chat for anybody that would like to read further or reach out to me. Thank you very much.
Yeah,
Namaste.
that's really nice presentation, and you gave a very good insight about this genetic disorders and the testing methods and all. That's really nice, and presentation was really excellent and very informative. Thanks a lot. Thank you so
Thank you.
much for the presentation. And since you provided your mail ID, definitely you will be getting some queries. And if we get any,
Sure.
definitely we are going to share it with you. Thanks a lot. Thank you so much for
Perfect.
your
Thank you.
presentation. Yeah, I expect a big round of applause from the people here. Thank you. Thank you so much. And now I move on to the next person, Srivijaya Narayan. And she is she's into clinical dental expertise and a deep regulatory affair knowledge person. And she is committed to promote healthcare innovations that meet regulatory requirements and provide real values to the patients. And she aims to enhance the dental care while ensuring the highest standards of safety, efficacy, and which are maintained actually. So, her ultimate goal is to align the regulatory compliance with patient-focused care to improve healthcare outcomes. That really sounds great. I'm just waiting to listen to the speech because there is a lot in the introduction. I just want to understand what she's going to speak in the presentation. So, Srivijay, it's all yours now, and you can start with your presentation.
Hi everyone, is it audible?
Yep.
Yes. Yes. Thank you so much for today, and there was a lot of great presentations, and even Rajashri actually spoke much about ethics and how we are going to handle the patient's data somewhat similar, or the basic of what I'm going to speak about in more of a regulatory aspects. So we spoke about more of a population health and disease prevention, but our mission as a healthcare professional is also to heal and also to protect. So, but I would say there is a silent epidemic that we are actually missing. That would be the ransomware attacks or the cyber attacks, which has been happening in the hospitals or the clinics in the day-to-day basis. So I would say one of the major breach that happened in US, there were 2.7 million Americans had lost their personal health data that has been stolen from one of the hospitals and the dental chains as well. In this, we are just not talking about the cybersecurity issues. It's actually a public health crisis. So the digitalization of the healthcare is exposing vulnerabilities that threaten everything we stand for. Can you share the presentation, if you don't mind?
Yeah, we are going to do it for you. Yeah.
Thank you. So yeah, we are going to talk about the sector that is the dentistry, which has already been under attack, not only in US but all the several areas of or the several countries, and it is not just the one part; it's a warning sign for all the healthcare sectors as well. Can we move on to the next slide, please? So this is what the modern dentistry actually looks like. So every tool that you see here, whether it's a 3D scanner or the CAD/CAM systems or the AI diagnostic software, is essentially a computer processing a patient data. Though with these, AI can flag the areas of concerns that actually a dentist may or any other dentist in the world might miss, but the same sensor can also store the biometric data as well. That AI access patient histories, revealing for more than dental health, like it can be insurance data, or then it can be SSN, or it can be any other payments or future or previous histories that's been present for that particular patients. Though we are embracing all these digital transformation in dentistry or any other part of the healthcare, but if we consider a smaller healthcare facilities, we are not understanding the implications or the challenges or the consequences that the cyber things or the digitalization is implying on us. So we are actually creating a treasure trove of data with minimal protection, to be honest. Can we move on to the next slide, please? So here is what troubles the most. As you can see, there are a lot of numbers, and the numbers are not small. The communities which are most vulnerable to these health disparities are also most vulnerable to these technological failures. For instance, as I've mentioned before, the AI diagnostics tool, which used to do disease diagnosis, whether it's a dental disease or the healthcare disease, has been trained with 80% of the data with Asian data only. But if you have to use that particular AI software in any other diverse population, the accuracy tremendously drops. So the rush to the digitalizations in the healthcare is widening gaps we have worked decades to close. So also the rural clinics or the rural hospitals, they can't afford cybersecurities or like they can't afford the IT person as such. The community health centers lack these cyber health support. The same technology meant to democratize healthcare is creating a new barrier among us. Next slide, please. So, if you see this growth trajectory, the dental software market is actually doubling in a decade. The AI accuracy has reached 98.8% in controlled settings, and practice management softwares are becoming a 7.6 billion industry. Even though the companies are getting a lot of money out of it. But if one thing goes wrong, the entire company will be like sued or there will be a lot of financial loss. We'll be talking about that in later. But yeah, so every month or every year, the healthcare faces like 1.4 billion cyber attacks. And if you take small practices like dental clinics, whether it's a very small practice, they have just started and incorporated the AI dental systems, they are the primary targets. So they have a valuable data, but they don't have that much of protections. So when a rural health clinics get ransomed, it's not just an IT problem or like it's not just one particular patient problem that will create a more of a, like a public health emergency because patient will not be able to get their medications, people will not be able to get the diagnosis immediately that they have to, and the preventative care just stopped right away there. So the shift from the paper records that we have been using or like we are using right now as well, theft to more of like a sophisticated hacking practices right now. And this fundamental change has created more of like a healthcare vulnerability. So this is more promising concern. And this is not about like an individual concern, as I've mentioned before. This is more of like a population level or like more public health level threats. Can you move on to the next slide, please? So yeah, now we have spoken about like what is the thing, how the dentistry is being hacked with the cyber things and all. But coming on to my aspect, like what's the regulatory point of view? So before and all, like before March 2023, FDA, that is Federal Drug Administration, they told like, okay, fine, if you're having a cybersecurity or like an AI thing in your medical device, you don't have to give much of like documents or like reports to us. We will approve it. But after March 2023, the FDA mandated that every medical device that has an AI or the cybersecurity must have to go under extreme scrutiny. They have to provide the records, they have to provide the documents, they have to tell what the data is being used for and what all the data have been collected and what the end result of that particular data. Everything have to be provided to FDA if you're using the AI or the software in your medical device. From my perspective, as a regulatory perspective, it is kind of frustrating because you have to submit documents, you have to make a lot of paperwork, talk with FDA, and talking with FDA is actually a very big thing. Like you have to make a lot of effort and you have to prepare for everything, and that's like a barrier between a good care coming into the market and like making a lot of paperwork and doing frustrated things. But if you think in a different way, or if I have to reframe this in a different way, uh, there were drugs which in the previous years they had like medical interventions and they need a rigorous oversight to prevent harm. that apply same to the digital health tools as well. So when an AI misdiagnoses, when a hacked device delivers wrong treatment, when compromised records destroy lives, that's a medical harm too. So the new requirements aren't bureaucracy, they are public health protection. Yes, approval takes longer. There will be a financial cost for that. The compliance will be costing more. But the alternative is that the unchecked technology harming patient is unacceptable. So the challenge for us as a healthcare leaders is ensuring these protections don't become barriers to care. Next slide, please. Actually, this data and how the AI fails in the diagnosing while examining thousands of patients is that even though it outperforms the humans in sensitivity, as I've mentioned before, as a dentist like me or like any other dentist, they would not be able to accept or like they will not be able to see the subtle changes in the dental cavities or like the dental tooth as such because those subtle changes are imperceptible to human eyes. I'm sorry. But with AI, we would be able to detect all these with the sensitivity of course, like 88% when compared to that of the human eye. But some AI software, if it is like hacked or if it is not working properly, as you have told before, then the patients who doesn't have any diagnose or doesn't have any disease will be misdiagnosed, have like they are having that particular disease. And if the patient is already having the disease, that it will tell like, no, the patient is not having the disease. Like that, there are like 136 patients that have been misdiagnosed and 668 patients who have like missed the diagnosis, later causing serious dental infections. I would say these aren't just like statistics. They are people harmed by overconfidence, I would say, in technologies as well. So for population health, this variability is catastrophic. That 88% heterogeneity means the same AI performs differently across different populations. So the technology trained on one democracy or like the one demographic area, as I've mentioned before, the if you use it in a diverse community, it actually fails. So we are potentially systemizing health disparities through biased algorithms. So can you move to the next slide, please? So yeah, as I've mentioned before, the smaller clinics are the potential targets for the ransomwares or the cyber attacks because they are the soft underbelly of healthcare cybersecurity. We have all the data value of large hospital, but only some of them spend that money to protect the data. So in that case, many small clinics and hospitals are lacking that protections. In January 2025, the 2.7 million patients affected by breaches, they aren't just the dental records, they are the comprehensive health profiles, whether it can be insurance information revealing those pre-existing conditions or the payment data or the family history or the financial history, whatever. It's like a lot of data that will be out of the system and it can be used by anyone. So for public health surveillance, compromised data integrity means we can't trust our own statistics as well. So, how can we track the disease patterns if the underlying data itself is affected or altered? How can we plan these interventions if patient records are held hostage? So, all these questions rise if you are like going to have like a small clinic with a dental device with AI softwares and cybersec systems. It's going to take a lot of toll on a dentist who is going to build that particular clinic with all the time and energy and money. They also have to look upon the protection that is actually needed, more lot of thought behind that. So I think even though the small practices now are getting more awareness towards this, how we can like protect the data, and even though they are taking a small patient name itself, like even that the patient is going to give on the trust or the hope of that of the doctors, as Rajshri mentioned about the ethical and ethics. So as a trust is basically that you go to a dentist or like you go to a psychiatrist, you would be giving all the details based on the trust on the particular doctor or the confidentiality between you and the doctor. So that all the things that will be in the dental software as such as the dental disease or the conditions about it. So everything has to be maintained and protected even though it is a very small information of a particular patient. Can we move on to the next slide, please? So I would say cybersecurity must be a priority and it may cause a cascade of effect because when a healthcare facility is breached, a damage ripples outward. The financial impacts, like approximately $5 million, which is enough to close smaller practices. But the real cost is measured in delayed care, lost trust, as I've mentioned, and compromised health outcomes. There are also 30-year family practice which is being dissolved because of a breach, because the patient felt betrayed, staff morale plummeted. The psychological impact on providers is severe because we entered healthcare to heal, not to manage cyber disasters. From a healthcare perspective, when practices are closed due to breaches, we lose access points to care. And if you take a dental care itself, like it's not just a dental care, it's actually related to other systemic conditions as well, like cardiac health, diabetic, and pregnancy outcomes whatsoever. Everything has been like interrelated. So, lost dental practices means lost opportunities for this integrated multidisciplinary care. Can we move on to the next slide, please? Yes. FDA has now become very strict after March 2023 Enforcement Authority Act because they told like, yeah, you need to submit all that we are asking us you to do. Because before that, it was like, yeah, you can do whatever you want. If the medical device is having AI or cybersec, it's fine. Like we will approve the device, but it's not after March 2023. And they have also created a 5 pillars for protections. So the one would be like SPOM, that is like software bill of materials. As you can see, like every product or like every ingredient or every what's it, if you are buying a snack or something, you will see the ingredients, what's all present. That's actually the software bill of materials, like what all the components are present or what the software are you using. Are you using any firewalls? Everything have to be mentioned in this software bill of materials. They need to know immediately if the something goes wrong in your device, what it is affected, and how can it be overcome with the probable solutions. And the next would be the coordinated vulnerability disclosure. So we would be able to create a safe channel for ethical hackers to report flaws before the criminals exploit them. So there will be a team of people like who can give them like, yeah, this is going to be the problem in the future, or like this is like a probable problem that's been happening around. So we have to be aware of that in our particular dental setup or the healthcare setup. That's what this team actually does. So we would be able to know whether there is any vulnerability in our software or in our medical device or dental device, so we can like overcome it. Next, the post-market surveillance. So in the regulatory aspect, it's not just only the product getting into the market, it's actually the we will be thinking or like we will be looking upon like after getting into the market how the patient is using, is there any adverse events or is there any deaths being reported. Even I think like last year in King's College London, I guess so, there was a cyber attack and one patient died. So death reporting to FDA is like a very big thing because even one adverse events have to be reported immediately to the FDA before even like that patient itself like reporting directly to them, because if you're getting a death report, then it's going to be a very big scrutiny for you from FDA to your company or the software or the device that you are being manufacturing. And refuse to accept authority is that FDA can now reject unsafe devices. This gives the regulation teeth. So this frameworks that we have mentioned before isn't just the red tape. I would say it's a systematic protection which is being modeled to these public health principles. So we have to prevent this so that we can like detect early and we can like respond early before everything has been like hampered or like or the whole company is going to bankruptcy. Can we move on to next slide, please? So SAMD is basically like software as a medical device. So software as a medical device is basically like you would be having a device or like for instance there is a glucose monitoring device. So in that you are like using a software to operate that particular glucose monitoring device. So that is actually called as a software as a medical device. So the matrix that you see here considers the healthcare situation's severity and the information significance. So scheduling software for routine cleaning, it can be like a lower risk, and but the AI diagnostics like oral cancers or like the AI diagnostic tool that has been like invasive, but also like important for more serious or life-threatening disease conditions. This needs a strictest oversight. So understanding this classification helps the predicts cost, timeline, and requirements. So it's like focusing the vaccination efforts on the high-risk population. We protect where the potential harm is greatest. So that's how this risk classification actually like evolves or like revolves around it. So I'm not going to talk much more about it because it's more of like a regulatory aspects. And if any of you are interested, I would like to explain it more in via email or like via any other chat as well. So understanding the classification actually helps all these things to the lessen the cost and the timeline. And it's a difference between like a 6 month implementations and a 2 year struggle. So can we move on to the next slide, please? Yeah, the pathways to safe implementation, there are like different pathways for the FDA to approve your particular device, whether it's like a 510K or PMA or de novo pathway and abbreviated 510K. There are various pathways that you can like give or like make your product get into the market via FDA. So even though the success factors are clear, like complete documentations and especially cybersecurity affects since September 2023 gives you a strong predicate devices for comparison, and also the clinical data meeting the FDA standards. All these things are interlinked so that like you can bring a safe and more effective and more public safety product into the market rather than just bringing a product into the market. So for healthcare professionals or the leaders. So this means like budgeting not just for the technology, but also for the compliance as well. So it means the longer implementation timelines, but safer outcomes. As I've mentioned before, if you're not like able to put that much money at the beginning itself for the waivers effect at the end, you would be able to save a lot of money and you would be able to cut short the financial loss that's going to happen waivers in the end. So in that way, you would be able to get a much more better results and you would also sustain your business in the market as well. So it's actually being rushing towards the market and going a step by step in a more effective and a safe manner, keeping the public health or the public safety in mind. That's what the FDA actually needs. So if you are giving that particular things, then you would be able to get your product approved into the market. Can we move on to the next slide, please? Yes, cybersecurity, it's just not only you do at the end stage or like it's just not only you do at the beginning stage. It's actually a continuous process. So it's from the conception through the post-market surveillance. So this life cycle approach mirrors how we handle the infection control. For instance, when I was doing my master's, so we used to sterilize our surgical instruments daily and we used to clean our dental chair daily. That's mean like it's like a continuous process. You don't want to contaminate the area. You don't want to cross-contaminate the infections that the patient had before, whether if the patient is going to be treated later. So that's how the process is. That's how the security also works. Like it has to be throughout the process, whether it's from the designing phase till the post-market surveillance. So in current practices, dentists have made security as routine as sterilization and monthly drills, continuous monitoring, and also rapid response protocols. It's not paranoia, it's actually a dentist or like the healthcare professional's responsibility, I would say. And in each phases, like a design phase, it will be including the threat modeling, and the developmental phase, you will be having like cybersecurity frameworks, and in validation, you would go beyond the function to cybersecurity, and the post-market surveillance would involve the vigilance activity as well. Can we move on to the next slide, please? So, AI performance in the real world is so, yeah, these metrics, as I've mentioned, like sensitivity with that of human eye and with that of the AI, which are imperceptible to the human eyes, we can like detect the disease conditions or the diseases which is not being diagnosed by the healthcare providers. These metrics show both promise and actually peril as well. So AI achieves 88% sensitivity versus 84% for humans. The AI that's 95% accurate in ideal condition drops to 60% with older equipments or diverse populations. So for health equality, this is crucial because we risk systemizing disparities if we don't validate across all populations we serve. So the message is clear that AI augments but doesn't replace the clinical judgments.
Right.
So it's a powerful tool which is required in skillful or like skilled hands because even though there is AI, we can do everything, but it needs a human supervision. It cannot be done on its own because it can give more of false results because how you train the data, that's how it will give the results. If you train with good data, it will give you the good results. But you have to cross verify it whether the data that is being produced is valid and also it is accurate as well. You cannot just use that particular data or the particular results as such in your practice or like as such in the research statistics or whatever. It has to be cross verified under human uh, skillful hands or like under human perception, like whether it is accurate or whether it is not. That has to be concluded before using that particular things or like particular diagnosis that has to be made. Can we move on to the next slide, please? Yes, healthcare's digital future is arriving fast and it's already been started more effectively and efficiently. But AI diagnostics achieving over 90% accuracy right now. The teledentistry is expanding across the underserved populations, and the predictive analytics is preventing the disease before even the symptoms is occurring. And on the other hand, FDA has adaptive frameworks for continuous learning systems. So based on the upgradation that every software is bringing or the every medical device is bringing, the FDA has also been accustomed to, okay, if this is coming, okay, this is what we need. If this is coming, okay, this is what we need. That's what like the AI has also reframed their, what to say, the guidances and the regulations. But I would say the innovations without security is just disaster deferred, and we must demand both the progress as well as the protection. So for public health, this means we have to rethink how we deliver the care. We have to track the patient outcomes. We have to protect the populations. The opportunities are transformative, but only if we build on a secure foundations, right? That's what it actually means. Everything like we need a base should be like very strong so that like we can build our uh, the building or the company or the market or the financial aspect. Everything has to will be like over grown in a couple of years. So can we move on to the next slide? So the practical implications, I have already spoken a lot about this, but you have to start with the regulatory pathway selections. We spoke about a lot of like different pathways, how to get the product to the market, whether it's a 510K or abbreviated 510K, PMA pathway, or like de novo pathway. So we have to have like a comprehensive documentations, we have to submit it, and the continuous monitoring and update has to be done so that we can like transform the compliance from more of like a burden to a competitive advantage. Can we move on to the next slide? The risk management in healthcare technology actually follows this ISO 14971 standards because this will able to identify the hazards, whether it's the probability, severity, or evaluate the acceptability and also monitor continuously. So this matrix is not theoretical, it's actually a practical that's been used day to day in medical device companies. So high probability, severity, or like uh, based on the immediate actions, or it's like outbreak response. We don't debate whether to act when lives are at stake, right? So we have to make whether the risk is going to be there and what kind of risk, whether it's based on the probability or the severity, they have to be monitored and get back to the solution immediately. So every risk that we identify in this via this risk matrix, we will be able to mitigate and protect the patients and preserve the trust basically in the healthcare innovations. That is the baseline for all the healthcare technologies that we are building actually. Can we move on to the next slide? So yeah, these are all the key messages I would say. So there is digital transformation, which is unstoppable, but it is also vulnerable as well. The security must be designed in and it cannot be added on actually. And compliance drives both innovation and protection. And the $4.25 billion dental software market represents just one segment of the healthcare digital future, but the success belongs to those who embrace both the opportunity as well as the responsibility. Can we move on to the next slide, please? So these are all the key takeaways that we have already spoken about, and we have to use the compliance, we have to use the risk-based approach and the regulatory strategy to bring a more safe and effective, and keeping the public health or the public safety in mind of the manufacturers or the business-minded people or the stakeholders, whomever it is. We have to look upon the public safety more than just getting the financial part or the just getting the reputation part of the for the business. So that's what the whole aspect of, even though the cybersecurity is going to be within your medical device or like within your dental devices, it has to be protected, it has to be monitored. There should be a human supervision as well. Can we go to the last slide, please? Yep. As Paulson said, like regulations need to catch up with the innovation, and in healthcare technology, I would say it's finally has. So we, the healthcare professionals, we are in great responsibility, and we understand both the promise of technology and the vulnerability of those we serve. So even though there is a digital transformations of the healthcare, and it's actually like strengthening rather than undermines the trust our patients place in us. So we have to look upon all the ethics that we have spoken about and all the regulations that we have spoken about in the previous slides. We have to think upon all this before getting our product, or like before thinking about the progress that we want to make in our healthcare industry. So thank you everyone for your attention, and thank you for listening. And I hope like we commit to make a more safer and innovative healthcare in the future. Thank you.
Yes.
Yep, that's a really excellent presentation, and you're very clear in your presentation, and the slides are also very excellent, very informative. Thank you so
Thank
much.
you.
It's one of the best presentation we had today. So
Thank you.
it's really nice. And any queries, definitely we are there to get the queries.
Sure.
If we get any, definitely we are going to share it with you. So
Sure.
it's perfect presentation. And
Thank
thanks
you.
a lot. Thanks for your time. That's excellent. So I expect a big round of applause for who is for presentation. Yeah. Thank you. Thanks a lot. Thank you so much. And now,
Thank you.
next, I move on to the next presenter, that is Faiza. So, she is actually a passionate dental health professional and an educator also. She has a diverse background that includes experience in both an NHS and private dentistry, and she has done a lot of leadership roles in both clinical and the tech environments. And today, Faiza is focused on merging oral health education, community impact, and digital innovations. So that is really very interesting. I just want to jump into the presentation. Faiza, if you're available, we can go ahead with the presentation, and we are waiting what you're going to present today. So we are just waiting for Faiza to enter the platform. So once she is in, she'll start with the presentation. So we're just waiting for her.
Okay.
Yep. So can we see you?
Hi, everybody. Can you hear me?
Yeah, I can hear, but I can't see.
Good afternoon, everybody. My name's Faiza Khadija Arshad. I can't actually see my own presentation at the moment, so I can just see myself. Can you guys see my presentation?
Yeah, definitely. We are going to help. We are going to do it for you. We are going to present your presentation.
Okay, lovely.
Yeah. Great. Yeah, one second.
So, guys, just whilst we're waiting, I'll just introduce myself. So, I am 28 years old. I'm from Manchester, UK. I started off a journey. I wanted to be a dentist. It was my passion from very young. I got 13 GCSEs, and life after high school is what I'm about to speak about today. What my career pathway went from clinical to where I'm at today. So, just let me know when you guys are ready with the presentation. It seems like I sent a second one. This seems like the original.
Next slide.
Sorry, guys. Okay, so as a dental nurse with experience across both NHS and private dental practices, I worked alongside the NHS one-on-one service. I advanced my clinical skills as a dental nurse by completing fluoride application, impression taking, a couple of post qualifications. I felt like that would help me better my personal statement for a dental degree. I went to a sixth form originally. I initially dropped out of my first year of sixth form, and I did a vocational course with a placement for dental nursing, as I felt like I wanted to go straight into work. I wanted that experience. I wanted to know what dental terminology was. And I just wanted to get that more first-hand experience, starting from the bottom, and see where I go. Again, it's not very traditional, and we'll delve in a little bit deeper as we go along. Just working alongside the president of the British Dental Nurse Association, I held a conference at the National Dental Conference in Birmingham at the NEC this year also. I like to promote oral health education. I like to inspire dental nurses, trainee dental nurses. I TikTok create oral health and dental nursing tips. So I do quite a bit with my main base career, which came from dental nursing. I witnessed the transformation in technology from when I remember the days I used to paper chart to now learning software of excellence, learning systems like R4. Again, very, very different to when I first started out to where I'm at today as a 28-year-old. I believe there's so many more systems out there. Every year we have the National Dental Conference where we meet over 1,000 exhibitors of, software, new equipment. As the lady that had just spoken to my before myself, is it Srividya? It was very, very interesting that you were talking and touching on the fact that AI is, that is quite, a little bit of a grey area. It needs regulating. It's quite new. There's a lot of doctors that are quite unfamiliar with this type of technology. So, just out of personal interest, I actually, if you would like to just go to the next slide, sorry, just whilst I'll go into my next point. Guys, if I talk too fast and you need me to slow down, does anybody give me a heads up? Sorry about this. Okay, so I'm just going to delve in a little bit more of the dental nurse. So the role of dental nurses today, I do believe we're more than chairside assistants. I believe we are key educators of oral health just as much as a dentist. And this can be through word of mouth from front of the house. This can be from our children, our partners, what we go on to do our post qualifications in. I feel like dental nurses have advanced themselves. I've heard of dental nurses actually moving abroad, relocating, going to Australia, places like the UAE, becoming hygienists. I just feel like, the role of dental nurses today, from the social experiments I do with the general public through my social media platforms. I most recently posted a video of my time as a dental nurse. I'm just reaching 200,000 views. I got over 1,000 responses and nearly 7,000 likes, and real life engagement from so many women from all over the world, not just the UK, of how to get into this career. They really loved what I did, and I still am to this day replying back to so many responses. And the fact that myself, which was just a dental nurse, can bring this much engagement. I'm actually sitting on 190,000 likes on my TikTok account, which I just started off as a dental nurse in my practice, just made for fun. So the fact that now our younger generation and generations to come are realizing the monumental shift and dynamic between doctorate and assistant, and what an assistant can actually extend their scope of practice and actually become, I'm not trying to be biased, or I feel like we're a lot more open-minded than the regular doctor or dentist or whatever clinician, just because we are looking for passive income streams that also help us better ourselves and grow into our career pathways quite naturally. And dental nurses now, I feel like they definitely do extend the role of more than chairside assistant, just due to the fact that I've lived this personally myself and that I've trained over hundreds in my decade-long experience as a nurse of trainee nurses who have now gone on to do the most amazing things, going for roles as, working for the president. One of my friends just got promoted to the president of Society of British Dental Nurses, who is now traveling up and down all of the UK with new policies. She's making sure there's no toxic work placements. Everything that we personally went through in our careers, we've now actually became leaders of our own, and we can really, really help, not just staff, but the public, the care, the companion layer of care we're getting between the clinician and the assistant and the patient themselves. So I do believe we are very, very, powerful advocates, and I do definitely believe we are the key players in adapting digital systems. As we have CPD, we have to do, I believe, just as amount of professional hours of verified CPD. We do first aid training every year. We keep up with all sorts of different legislation and regulation. We have to do courses. We get micromanaged by practice managers. So I do feel like the role and the title is just as heavy and awarding and something to be very proud of as a dental nurse. And this is why I feel quite strongly about it. If you just like to go to the next stage. So digital tools in practice, practice management systems. Every practice manager I have seen, I recently, in the last couple of years, actually enrolled onto a practice manager course. I passed the course. I trialed it at a dental practice in Milton Keynes. I trialed it for 1 year. The fact that there was so much paperwork, it was quite demanding. It was quite pressurous. I definitely felt like if we had more modern digital systems in place, I could possibly have been a great manager. And I'm very, very appreciative of the principal dentist that actually allowed me to have a go at this. I felt like I was quite good. We passed the CQC inspection. The nurses were very, very loyal to ourselves. So the staff retainment was quite good. It was just the fact that quite put me off the idea of staying in a management role was the fact that there's just so much, paperwork to go through. There's a lot of old systems that just does not quite work for somebody that was born in the 1996, who's now developed in a generation of old systems to new systems. So I quit clinic. I actually quit that job. I resigned in that role, and I wanted to try something new and different that didn't give me amount of stress. I wanted a good work-life balance. So at this stage, I actually completed an access to higher education science course, and I then got an unconditional offer at the University of Bradford for biomedical science. So I thought, hey, this is quite different. I never quite got the route to straight into dental surgery. Even though I've got all this experience, etc., I just could not. I got to every interview stage, but I never got the place onto a dental degree. So I accepted the biomedical sciences. And whilst we were on this biomedical sciences degree at the University of Bradford, is known for one of the best life research science departments in the whole of the UK, and they were definitely developing new AI assisted diagnostics whilst we were having our labs, whilst we were presenting when we were doing group presentations. And when I was at university, I do believe COVID had hit, so I did my final 2 years online, and I was one of those students that were the first, I believe, rollout to do our university exams through an online system that nobody was new to. It was very, very new to ourselves. Nobody knew how to use this. We were using remote VPNs, and it was quite overwhelming as a student at that time, 2019, 2020, 2021, this era for myself. I just feel like it was quite a blur due to the fact my whole life that I knew had gone online, and I feel like I've been online ever since. It's quite hard. It was quite hard for everybody to connect back to real life due to COVID. The e-consents, automated recalls. I noticed that practices were now having iPads, and we had longer reception lines because everybody had to sign consents on iPads, and each practice wanted to cut costs on revenue. So we only had 2 iPads for, let's say, if it was a 5 surgery practice, you can sometimes have nearly up to, I believe, 20 people sometimes waiting in your waiting room. And I found this at my time working in a non-clinical role. I found this quite problematic as staff. It was quite pressurous on us, on ourselves. It was quite frustrating on patients. It was quite, I felt like we couldn't give all our attention to the patients that really, needed that the clinicians are doing their job in the clinics. But us frontline staff, we're overwhelmed with so much all at once, and then we've got iPads that we're not competent on? How about the receptionists that are late 50s? They've been working for the NHS for so many years, and nobody really thinks about how AI could now help staff for the front line. Everybody is so, I believe, blindsided by the clinicians and how they feel and how they can give a better service. I feel like if we overall connect and anchor this AI generation with the clinicians and us frontline staff, I do believe we will make a better overall, experience for not just ourselves, but the public too. And that brings me back to my point of maintaining that continuity of care. So this AI systems, I do believe it can help, relieve stress of doctors, receptions. I feel like dentist notes, etc. I do believe AI could definitely really help. I believe with security AI, I do believe that data and privacy is a lot more secure. I do, from the previous speech that we just heard, I just found it really interesting that to hear the perspective of how breach of data can penalize a practice, etc. And it's not something that you would think of every single day. But I just wanted to let everybody know I quit my clinical duties 2 years ago, and I actually trained with an American corporate to be a tech advisor. So I work remotely for tech solutions. Anything I can fix from my laptop using certain software systems that I've been trained on. It's all government process, so we work under a VPN. I would never have known this or had learned or had known any of this technology if I hadn't had been trained by this company and left my clinical role. If we'd just like to go to the next stage, please. So public engagement and social media. When I left my clinical role, I left practice, so I started to work in this remote tech role. I also started to create more. So my TikTok, I started to have a lot more engagement. As I mentioned before, I'm at 190,000 at the moment. I started to build on my LinkedIn. One of my highest posts reached up to 40,000 professional members. I was really big on personal branding, of how us as professionals, every stage of our lives, in our professional development and in our personal lives, how we like to interlink the two and marry the two, and to just showcase all your work. It's just something I started to work on, and it's really, worked for myself. I feel like, so I feel like from my TikTok, I have made multiple businesses. I am in a better position in life financially. It's given me freedom. It's given me a better work-life balance. So the appeal of tech and tech solutions, AI, and working within the tech world really, really, really did appeal to me a lot more than finishing my dream and passion to be a dentist, which I'm not putting a halt on that as of yet. I feel like I may save that for my 30s. At the moment, I'm really enjoying learning technology. My social media platforms empower the workforce. I'm always sharing digital CPD. I complete all of this myself. So,
yes, I'm great. Thank you so much. Yeah, how are you? Good, good.
Sorry, does anybody want to let them know the mic?
You got invaded by text.
I'm sorry. I'm sorry. One of the speaker, I guess. Can you just please mute your mic? So Julie, I'm sorry. If you can just mute. Yeah, it's done. Please continue. I'm sorry.
Okay, lovely. So, where was I up to? I was up to CPD and e-learning. So I just wanted to let everybody know that I keep up with my dental CPD. Even though I'm not within the dental world at the moment, I still keep myself educated and everything. I follow the right pages. I follow the right people. My network, again, very amazing. Implantologist, endodontist, doctor, everything that I could possibly want in a catalogue of what I feel is the best influential and mentors I definitely have found within my social networking. Burnt out prevention via efficiency tools. Again, I feel like this stage of my life, I've had a lot more calmer, a more peaceful time than, let's say, my younger 20s, where I felt like all of this was quite overwhelming to me. The fact that we now have all this new technology, it has really relieved the stress of the what I would say modern age working class, and the fact that technology has created so many new career pathways and innovation. Again, I just want to let everybody know, I just want everybody to think about, I was 16 and I started off as a dental nurse. Along throughout my professional and my career journey, as a 28-year-old today, I can say I've created an AI software that helps accessibility needs. It enhances accessibility needs. I am actually a Dragon's Den finalist. I found out a couple of days ago for my idea. So out of 600 global ideas, I'm one of the finalists, 5 finalists for this specific AI software I have created, and I'm looking to co-develop with Sky. I'm not too sure if you guys have heard of Sky Global, but they're one of the biggest telecoms, broadband, Wi-Fi, everything, Sky Sports, they're an absolutely massive company. They did their first ever Dragon's Den competition, and I'm the first ever British Pakistani girl to actually pitch my idea to 4 really strong dragons. One is the CEO of Italy. One is the CEO of the entire Sky Group. We have Priya, who is the chairman of new revenue officers. And then we have Mr. Piers Linney, who is an original dragon who has made 9 investments on his time on national TV. Now, I just started off as a dental nurse, but the fact that I have been chosen as a finalist for my AI software idea, which I can develop with Sky, remotely software download in people's equipment. It helps healthcare needs. It helps people. It's to target the digitally excluded. It helps visual reminders, onboard navigation. I can integrate my software to the NHS. I have a GP in Manchester who overruns over 150 GP practices on board and on my team. I have 2 celebrity dentists. I have the CEO of Rue Dental, and I have the CEO of Lumi Dental, who has just had her own spread in Grazia magazine. Again, my social network, my social media, my social network, my knowledge of dentistry and technology, I've combined the two and I've created an invention that could help people globally. So I just wanted to say that in the UK, around 16 million people, about 24% of the population have a disability. Globally, 1.3 billion people, or 16% of humanity, experience significant disability. So the AI software I have created based on everything I've learned in my lifetime and in my courses, I've now built a solution which we're ready to co-pilot with the NHS and have a diverse user group to test and trial. And it would be something that I would be looking to scaling to every brand, to every practice, to every clinic. And I'm really honored that I have this space to talk about something that I feel would definitely change the world, and it's very, very new. It's never been invented before. And the fact that I have NHS backing, again, it's, something superb. It's a new entry pathway. I could make jobs from this. Again, it all started off with the digital era. My final reflections is from everything I've spoken about so far, is that embracing these digital tools, it's everything digital now, as it's all very overwhelming, it's very brand new, it's quite foreign, the terminology is foreign to us all. It's something that we're quite apprehensive about. I definitely do feel like if we are now a lot more, I believe, aware of these changes that are happening, and if you speak to a lot more of the younger generation, the generation that are still students, that are still looking to develop the professional careers, you'll notice a lot of the NHS workforce we are struggling as a nation because a lot of the qualified professionals, just like myself, we actually developed a new skill and we made entire businesses of it. So the fact that we are following the rest of the nation, not the nation, the globe, in this new AI assisted digital era, I definitely would say upskilling and educating yourself in this, keeping up with all sorts of little segments. There's loads of talks on YouTube, sometimes podcasts. I believe Mr. Stephen Bartlett, he actually spoke at a dental conference for ourselves this year. He also holds a lot of tech, AI, entrepreneurship, a lot of podcasts. They're very, very empowering, empowers myself, and it really makes me want to promote this more and spread this message across to all generations that, there's a class here that are trying to find solutions and anchor the digitally illiterate to the digital literate, for example, like myself, and bring the two together so we have overall have a better experience. I've just got one final thing to say, and I believe my segment I can wrap up, if you guys just bear with me. So from basically my conclusion from all of this is, and the point I want to make across is from the dental chair to the Dragon's Den, my journey has been anything but traditional. I started as a dental nurse, hands-on, patient-facing, and deeply human. That foundation taught me the value of trust, precision, and empathy. But standing here today as a finalist for Sky's AI Dragon's Den, I realize I've taken those same values and transformed them into something innovative, a tech solution that still puts people first. This isn't just about where I've been, it's about where we're going. Whether it's in scrubs or in a pitch room, I'll always champion care, connection, and change, because real innovation doesn't forget where it started. So thank you guys. Thank you for listening to me. And I hope you really enjoyed my little speech and little segment here. Thank you.
Great. That's really a very fantastic speech from your end, and it's nice. Like you're into multiple things, and definitely you can utilize these platforms. Like we have got different conferences available for you, basically, because you said you're into AI.
Yeah.
You said you're into different verticals. So probably we will be definitely in touch with you, and whenever we are in need of your presence in different conferences, we'll definitely come back to you, because it's very
let's hope I
interesting.
win, guys. Everybody pray for me that I win and I'm able to develop my software and we're able to integrate and work with clinicians. And it would be lovely to hear everybody's thoughts in the comments. If you guys could leave me a little comment, it would be amazing. Okay, lovely guys. So have a lovely rest of the conference day. It's been amazing so far. Thank you again so much.
Thank you so much for your speech. That's great, and I expect a huge round of applause for the speech from my people. Thank you so much. I now move on to the next speaker. That is Jolie Roncliffe. So she is a 4 times bestseller book author, like for public speaker and a former solicitor. And she is a resilience strategist and visibility mentor, helping others turn adversities into strengths. That's really enlightening. That's excellent, even. And she leads a courageous conversations aimed at sparkling a real systemic change. That's very nice. And see, her work redefines visibility, credibility, and wholeness, inspiring others to embrace their stories and stand tall. That's really interesting. And I just want to see like how the presentation goes. And Julie, we're waiting for a presentation, and now the stage is yours, and you can start with your presentation.
Okay, perfect. I don't really have a. Let me see if I can share my screen.
We can
There we
share
go.
your. If you have your presentation, if you can just share with us, we are going to do it for you.
Oh, I see. Okay, so how do I do that? Or do I just fire away and talk away?
You can do it in your WhatsApp. Not a problem. We are
Okay.
here. We can support you.
Okay, all right. Yeah, I'm at a conference today and my other phone has gone missing. So Madasa was kind enough to send me the login details on LinkedIn, which was really, really helpful. So struggling just a little bit, but I do want to talk about mental health. So focusing on, from stigma to sustainability. So am I okay to carry on even without slides?
No problem. No problem. Please, we can see you. It's good.
Perfect.
You can go ahead. Yeah.
Perfect. Thank you so much. Yeah, I appreciate that. And I do apologize for the earlier background noise. So my talk today is focused on reimagining mental health. And as you rightfully said, my background is not academically mental health at all. So I speak today from a lived experience. I am somebody who's struggled a lot with mental health issues because of all the terrible things that have happened in my life. So I've faced a lot of adversity. I've faced a lot of things that could literally break you and reach a mental breakdown. And there was a day I remember vividly where I literally just went to the local shops to buy a pint of milk and bread for the children. It's a 2-minute drive, 10-minute walk, and I just could not find my way back home. I just blacked out. I was going through one of the most difficult times of my life. And in that moment, you question everything. When you lose your mind or when you lose your mental health, you pretty much have lost it all. So I speak from that today. But my focus really is on mental health in relation to men, because this month is Men's Mental Health Month. So one of my children, he suffered from mental health last year. He had mental health psychosis, a normal boy going to school, doing his A-levels just like anybody else. And then one day he turns to be somebody who I don't even recognize as a family. As a parent, rather, who we don't recognize as a family. My whole house is destroyed. We all have to move out because all of a sudden this gentle boy, this sweet son of mine, has become something that's totally different, all because of a mental health illness. I wasn't aware of psychosis at the time. I didn't even know what it entailed. But after that, I had to learn a lot more about psychosis, about just general mental health. So my talk is just really to those people who probably struggled with mental health, who've got loved ones who are going through mental health, and what we can do as a community, what changes can be made in relation to mental health and how things could be done better. I struggled to get him care because he would just turned 18. So they considered him to be independent at the time. But how can you be independent if your mental well-being is not such? How can you be somebody who's got consent when really your mental health is otherwise? So is those things where we need help, where we need changes to say, look, he is saying he does not need help, but he does need help. He doesn't know that he actually needs help because mentally he is not in that kind of mental state to be able to realize that he needs help. And I know that the struggles that I faced, I was not, and I am not the only one who's ever faced that as a parent, where the help that you're supposed to get from the public health, you can't get that because of systems, because of barriers, because of all these measures that we put in place to try to protect these people. But are these measures actually helping us, or are they causing us harm? So that's one point. And then the other one is there's a lot of social stigma, social stigma surrounding mental health, especially with men. Do they want to talk about it? Can they talk about it? And when they talk about it, are they going to be treated differently? That's with men generally, but I think it's more so with younger men. they are growing, they're finding themselves in society, and then all of a sudden they're faced with this beast that they themselves are trying to maneuver, trying to understand, and then they become a totally different identity. Do you talk about it? Do you not? So that actually, there has to be a societal change in relation to the societal stigma that pushes men to suppress these emotions, that stops people from vocalizing exactly what it is that they are going through. So men suffer in silence due to the fear of judgment, due to the fear of shame. And I think there has to be a campaign in relation to that. There has to be a change, because we know that suicide is a leading cause of men's death. So something has got to give. Generally in men, but we also know that statistically, Black and ethnic minority men, they face additional cultural and systemic barriers when it comes to mental health, getting access to help, and also talking about it, because societally and really culturally, it's almost like it's taboo to talk about those things. So my mission is to raise awareness in relation to that, because behind the silence, there are fathers, sons, brothers who are carrying the weight of the world on their shoulders, and they need a relief. They need a place, a safe space to be able to talk about their health, about their well-being. And I think it's important for us to focus on that, particularly this month, Men's Mental Health Month. Public health has to have measures like gender-aware approaches to normalize vulnerability and emotional expression in men. The public health must change. It must fund male-specific mental health programs and create these safe spaces where we as women, we can go and have a spa day, talk about things that are going on in our lives, talk about our mental health. But what do men do? Do they have a safe space? You know? So I believe that these spaces must be created, and I think that there should be a fund set aside specifically for those particular spaces for men. We should engage our men in community-based solutions, therapy alternatives, and prevention. Because in my view, strength is not in silence, and survival is not the same as healing. And most of our men, they are not healed. They are just surviving. And then that then spills over into relationships, family dynamics. Then you have trauma based on those relationships as well. So men's mental health is a priority in the public health. And I think it's imperative that all these changes are actually taken as a priority. We need to create an inclusive, non-judgmental space for men to speak and to heal. We need to move from a more reactive care approach to a more proactive public health policy that actually supports our men. We want them to be leaders. We want them to be the head of the family. But how can you have a head that's not fully functioning? We must train our leaders, teachers, GPs, and employers to spot the early signs, because I believe that if these early signs were spotted by me as a parent, or even the school where my son was going to, if that was spotted earlier on, I think and I believe that he would have received the help that he needed before it got into a psychotic episode. So there has to be early intervention in young boys, early intervention for young men. But I'm not discriminating against the older ones too. They equally need support. So I think we need to challenge the culture that says men must carry pain alone, because I do not think that carrying pain alone in and of itself is a sign of strength. So men don't need to be unbreakable. I say that, but then I've just written a book called Unbreakable. But at the end of the day, men should be able to show their cracks. They should be able to show that I am going through something, and then get the help that they need. So I think in summary, it's just let's build a future where every man is seen, is heard, and is supported. Let us build these things, infrastructures, policies, procedures in the healthcare system that allows our men to get the help and the support that they need.
Very good. Very good.
Thank you. Thank you so very much. I'm happy to answer any questions that you may have or that anyone may have. But really, this is a matter that's super close to my heart. So I just speak from that lived experience. I don't think there's anything as heartbreaking as seeing somebody who you love turn into somebody who you can't even recognize. And if that person is so dear to you as your own son, it gives a whole different meaning to mental health.
Yeah. Yeah.
Okay, I'm done.
You're done. Great. I thought still you're speaking.
That was
You're done.
I am done, and I can answer any questions that anybody can
No,
have.
that's really
but yeah,
interesting.
I've been
I was just listening to you, and I just want to listen more from you. You just talked.
It's very good.
No, I genuinely appreciate that. And I appreciate the opportunity to speak about a subject that's just really close to my heart, but a subject that most of us don't want to talk about, because there's that whole stigma, are you cuckoo? Are you this? Are you all the other things? But I think we all face mental health challenges, at different parts and points of our lives. Even resilience by its nature, it's, being strong, going against whatever it is that's happening in your life, rising above those challenges. But what if you don't and you can't because you don't have the mental capacity to be able to do that? I used to be against medication. I didn't believe in medication at all. I just thought people heal. But when it happened to my boy and the difference that I saw when he got the medication, it was just really such an eye-opener. So I do think that there's need for education generally to people who don't know, because if you don't know, you don't know, and you don't actually know what you do not know.
Yes. Very good speaker.
Thank you. Thank you so very much. I will not hog the screen. I will hop off. And thank you so much for the opportunity.
Great. Thank you so much.
Great.
And this really
Thank you.
need a great round of applause. That's great.
Thank you.
Great. That's excellent.
Very good.
Yeah.
Thank you very much.
Yeah, great. With this, I just want to close the session. So we have got some more speeches lined up, but for 30 minutes, I just want to go for a break, and so we will continue with the next speeches once the people are in, because we got the people from other parts of the globe, so people are slowly coming and joining in the talk. So I just want to take a break for 30 minutes, and after that, we'll plan for the next sessions. So the people who are there till now, who have participated in the conference, I thank each and everyone for spending time here and giving their talks on diversified topics, and which are very informative. And thanks a lot, one and all who are there till now. And we will start with the next session with other people. For now, we are signing off with the existing ones. Thanks a lot for one and all who are there here till now, and hope we may meet you in the upcoming Helix conferences and webinars too. Hope you have enjoyed this session, and hope to see you all in the next upcoming webinars or hybrids. And we will keep posting you the happenings, what we are going to do in the coming days. Thanks a lot, one and all. Thank you so much for your time. Great. Bye-bye, everyone.
Bye.
అబ్బా ఒక్క నిమిషం అంటే బాగుండేది కదా.
లాస్ట్ ఇచ్చారు. అది చాట్ ఎక్స్పోర్ట్ అది
వస్తుంది వస్తుంది వస్తుంది.
I'm hoping for one more hour. Is it Sarah? Mujahid, Stephen Lecom, Musa ఏంటది?
సార్ స్టీఫెన్ లీకో దీపిక
Adipka.
అండ్ వన్ అండ్ ఓన్లీ ద పర్సన్ మైక్.
Where is Rosie? Rosie నోటుకొచ్చింది.
ఎక్కువ ఎఫర్ట్ కష్టపడినట్టయితే లేదు సార్, సింపుల్ గా వెళ్ళింది.
But we are a little hungry, yeah.
ఇంకా లేట్ అయితే కోర్స్ తీసేస్తారు ఇప్పుడు అండి.
అంతే.
It's no issues. It's not bigger issue. I can cut it down. No issue. Let's go down. Let's have a
గురు కంగారు ఒక గంట మనం పెట్టుకోవాలి. ఒక గంట ఈజీ గంట ఉంది.
It's time for beer, right?
ప్రదీప్ ఇంట్రెస్టింగ్ ఉన్నాడు ఈ విషయంలో మాత్రం.
That is always interesting.
పెయిన్స్ తోనా?
పేషెన్స్ తో
ఒక్క బాటిల్
We get more questions.
ప్రదీప్ లేదా అలవాటు లేదా? వెళ్దాం, నేను రెడీ. మా ప్రసాద్ రాడు.
ప్రసాద్ ఏజ్ అంటే ఇంట్లో నుంచి ఇంకో అడిగింది సార్, దీనికి మొహమ్మద్ గారు లైట్లు కొట్టాడు. ఎవడా మొహమ్మద్ అని అడగండి.
తెలుసు తెలుసు.
The one who is asking for our what's that company? ఇది అడిగారు కదా, ఇది అన్నారు కదా సార్, ఏం వర్డ్ సార్ అది? కంపెనీ
ఏమి పోస్ట్ చూసావా విజయ్?
చూశాను రా.
ఏమని?
ఇది బిర్యానీ లాంగ్ ఉంటుంది సడన్
ఏమైంది?
తెలియదు.
వన్ సెకండ్, యూట్యూబ్ లైవ్ క్లోజ్ చేయలేదా? చేస్తున్నాను.